Hello, everybody. Good afternoon. Are we in the Sushruth Hall? And the session will be starting at 2:30. Can somebody hear me?
Yes, sir.
Am I audible, sir?
Yeah, that's right.
Yeah, hi. Dr. Shlok Gupta is also here. So,
Sir, hello, sir. Good morning. So, we welcome you all for Hello Diabetes Academia 2020. And I would like to, we have with us, so has sir disconnected? Hello?
yeah, I guess he has disconnected.
So I would request RX Events team to just coordinate with him.
Yes, sure, I'll do.
Okay.
Hello. Hello.
Hello.
Hello.
I am Dr. Makkad here. Anybody there in the hall? I can't see anybody.
Hello.
Yes.
Hello. Good morning, sir.
Morning.
So we
Morning.
welcome you for Hello Diabetes Academia 2020. And
Yes.
we're just waiting for
Yes, sir. Holy
moderators,
Mandir.
Dr. JK.
Dr. JK Sharma had joined. I think he's got disconnected again.
Yes, sir. So
How are you, Shlok?
he's just reconnecting. Yes, sir. And sir, he's joined. Okay, he's joined. So on behalf of Team Hello Diabetes Academia 2020 and International Digital Conclave, I welcome you all, and I invite Dr. JK Sharma sir, who is a senior consultant diabetologist in New Delhi, and as a moderator. So I invite you, sir, for moderating the sessions.
Thank you, Dr. Slok. Good afternoon to all. I welcome you all to this Digital Hello Diabetes Academia 2020 on behalf of the organizers. And I'm thankful to Dr. Sunil Gupta and the organizers for giving me this opportunity to moderate this important session. And this session will have 3 talks by Dr. Briz Makkad, by Dr. Sujoy Ghosh, and by Dr. Panikar. And each talk will be for 15 minutes, followed by 5 minutes question answers. So the first talk is about the hydroxychloroquine. And the speaker is none other than Dr. B.M. Makkad. I feel very happy to introduce my friend and mentor, Dr. B.M. Makkad. He is Senior Consultant Diabetologist and Obesity Specialist at Dr. Makkad's Diabetes and Obesity Center at New Delhi. He is the past Secretary of RSSDI National. He is the Secretary of Obesity Network in India. And he, at the present time, he is the EC member of RSSDI. He has a vast knowledge of the subject and also in obesity, and in the current scenario where HCQS has become very, very important, and also in the treatment of diabetes. So now I request Dr. B.M. Makkar to present this before the audience. Dr. B.M. Makkar, please.
Thank you, Dr. Sharma, for very, very kind words. I don't think I deserve that all those things that you mentioned in your introduction part. I would also like to thank Sunil for giving this great opportunity and put me as the opening batsman for the first session. As the topic has already been mentioned, I am going to speak on hydroxychloroquine, its relevance and role in management of diabetes. Hardik, can you upload my session? Hello, Shlok?
So we'll
Yes,
just
sir.
upload present. I request team RX events to kindly upload the session.
Look, it is already live
It
on
is
for
good.
the delegates. I will
Okay.
share the same screen here.
Okay, okay.
Sure.
Hello, diabetes.
Hello.
Login નથી કરેલું. એ વાંધો નહીં, આમાં ના કરે.
इनवैलिड अब नाम भेजेंगे लोगों को नाम और ईमेल आईडी हाँ
इधर सुष्मिता हॉल खोल के फिर उसकी स्क्रीन शेयर कर इसमें ज्वाइन करना है सुष्मिता हॉल खोल के फिर इसमें ज्वाइन करना है
Hello, anybody there in the hall?
Yes, sir, we are there.
I can't see anybody, and the session is still not live in the hall.
Okay, sir, let me check.
Please play this Indian Hot Sports 2:30 to 3:45 in Susrat Hall.
The Sushrut Hall, I have put the play, I have pressed the play button, but
Now this.
Dr. Sharma,
Yes, upcoming.
Dr. Sharma, can you see the session running?
No, I can only see the
Yeah, as of
that,
now, I can see slope on the screen and the.
now
No, I have entered the Sushrut Hall. I have entered the Sushruth hall. It is
This upcoming, if you, I think if somebody presses this upcoming, then they should start live.
now it is coming up.
It's not full screen.
You can make it full screen, Dr. Sharma.
Shared by our esteemed panel.
To bind to insulin receptor and activate the insulin action on the cell. So there is improved insulin action because the degradation is less, and the studies have shown that hydroxychloroquine leads to increase insulin levels. As it is dependent on the concentration of reaction. So studies have shown that insulin hydroxychloroquine leads to decrease in hsCRP levels, and this covers everyone for this restoration of islet structure, improves beta cell percentage and mass, and also leads to correction of the increased alpha cell mass. And this is, you can see in this slide, the patients treated, the rats treated with hydroxychloroquine had intact islet cell structure, better or preserved beta cell mass, and decrease in the alpha cell mass. Now, there are enough number of studies which have looked at the role of hydroxychloroquine in type 2 diabetes, and the initial studies date back to 1990, which is almost 30 years back, again showing benefit of hydroxychloroquine in improving A1C levels. Now, this was possibly one of the largest retrospective analysis of rheumatoid arthritis patients who were treated with hydroxychloroquine, prospective multi-center study involving close to 5,000 patients, and they looked at the impact of chloroquine, hydroxychloroquine patients who were using hydroxychloroquine for at least 4 years and never users of hydroxychloroquine, and the patients who were using who used hydroxychloroquine for more than 4 years had almost 70% reduction in the development of new diabetes. Another study which looked at patients with type 2 diabetes inadequately controlled on metformin and glimepiride, and hydroxychloroquine was given versus placebo. Significant reduction in fasting as well as postprandial glucose levels, and significant reduction in the A1C levels in patients treated with hydroxychloroquine. Another study which made head-to-head comparison between hydroxychloroquine versus pioglitazone added to patients who were inadequately controlled on 2 drugs. Again, hydroxychloroquine showed significant A1C reduction, but there was no weight gain in patients treated with the hydroxychloroquine as compared to pioglitazone patients who gained a weight of almost 3 kg. This is another study which looked at the efficacy and safety of hydroxychloroquine, was published in 2014, and also possibly was the basis of approval for hydroxychloroquine for use in diabetes. This study looked at the role of hydroxychloroquine once added to patients who were inadequately controlled on sulfonylurea and metformin max stable dose versus pioglitazone added to the stable therapy. So the study involved, initially more than 500 patients were screened, and of this 267 were randomized equally to both arms, hydroxychloroquine and pioglitazone. And if you compare the results at the end of 12 weeks, patients treated with hydroxychloroquine. Another study which made head-to-head comparison between hydroxychloroquine versus pioglitazone added to patients who were inadequately controlled on 2 drugs. Again, hydroxychloroquine showed significant A1C reduction, but there was no weight gain in patients treated with the hydroxychloroquine as compared to pioglitazone patients who gained a weight of almost 3 kg. This is another study which looked at the efficacy and safety of hydroxychloroquine, was published in 2014, and also possibly was the basis of approval for hydroxychloroquine for use in diabetes. This study looked at the role of hydroxychloroquine once added to patients who were inadequately controlled on sulfonylurea and metformin max stable dose versus pioglitazone added to the stable therapy. So the study involved, initially more than 500 patients were screened, and of this 267 were randomized equally to both arms, hydroxychloroquine and pioglitazone. And if you compare the results at the end of 12 weeks and 24 weeks, there was similar reduction in fasting and postprandial glucose, and similar reduction in the A1C levels in patients who were treated with hydroxychloroquine as compared to pioglitazone. This is a paper published presented at ACE meeting 2018 by Dr. Hemant Thakkar from Mumbai, again showing good impact on fasting, glucose, postprandial as well as A1C levels in patients who were given hydroxychloroquine add-on to 2 drugs. Similar results from Dr. Manoj Chawla from Mumbai. In addition, they also noticed that there is improvement in lipid profile. Another study which looked at comparison of hydroxychloroquine as compared to canagliflozin when added to combination of patients who were inadequately controlled on maximum dose of Vilda and metformin, and similar reduction in the A1C levels, similar reduction in fasting and postprandial glucose levels when compared to canagliflozin. Another study which looked at hydroxychloroquine add-on to basal insulin, metformin, and sitagliflozin in patients who had A1C levels 8.5% or more. And in these patients, addition of hydroxychloroquine resulted in improvement in A1C levels, improvement in lipid profile, and also some improvement in body weight. So add-on hydroxychloroquine significantly improvement glycemic control, and basal insulin. Another study where of hydroxychloroquine was assessed in 600 patients who were on metformin SU combination, and they were treated with hydroxychloroquine. Significant reduction in the fasting glucose, postprandial glucose, A1C levels, and also reduction in the improvement in the lipid profile. And there was no increase in the adverse events. There was 8 patients who had non-proliferative diabetic retinopathy. 7 were not linked to hydroxychloroquine, and the common adverse event reported was mild GI side effects. This is another study where hydroxychloroquine was given to patients who were poorly controlled on oral anti-diabetic agents and insulin glargine, and addition resulted in improvement in the A1C levels, improvement in fasting glucose levels, and more people, 44% of the patients achieving A1C targets of less than 7%. Another prospective observational multi-center study involving more than 1,000 patients where the hydroxychloroquine was added to 2-drug combination, and again showed significant reduction in fasting, postprandial, and A1C levels in these patients. And the study concluded that hydroxychloroquine is possibly a valuable therapeutic intervention when patients are not well controlled on 2 diabetes. Another study where again it was added to 2-drug combination plus glucose levels were also reduced significantly. There was 26% reduction in the total daily dose of insulin required also, and there was reduction in the inflammatory load. There was no evidence of any ocular complications or increase in retinopathy. This was an observational study presented at IDF meeting in Busan, December last year. Again, this was observation multi-center study, involved patients who had A1C more than 8.5 were on stable treatment with glimepiride, metformin, and basal insulin and glargine. They were randomized to hydroxychloroquine versus dapagliflozin, and the study showed that both the drugs led to similar reduction in A1C, and there was significant reduction in the dose of insulin requirement also. So if you look at the adverse event profile, again was similar. There was no increase in the severe hypoglycemia in patients treated with hydroxychloroquine. There are a number of studies which have looked at add-on hydroxychloroquine usage in patients who were on metformin, teneligliptin, metformin sulfonylurea, metformin, vildagliptin, sitagliptin, or in comparison to sitagliptin, vildagliptin, or dapagliflozin, and so on. And all these studies have shown beneficial effects. This was a recent consensus group, opinion which was published in the Journal of Association of Physicians of India. Again, validating the use of hydroxychloroquine in patients with type 2 diabetes. recent ICMR guidelines also mention this as an approved anti-hyperglycemic agent, and so is the mention in the RSSDA guidelines also as that hydroxychloroquine is approved medication for management of diabetes in India. Now let us look at the CV protection. This is one of the important study which was the retrospective incident rheumatoid arthritis cohort, and this was a study where the patients retrospective analysis of data patients having used hydroxychloroquine between 2001 and 13, and patients were classified as users or non-users, and the study involved more than 1200 patients, 547 users, and study showed that there was 72% decrease in the risk of cardiovascular disease in patients who were users of hydroxychloroquine. Another study published in OncoTarget in 2018, which looked at association of hydroxychloroquine treatment with cardiovascular morbidity among patients who were having rheumatoid arthritis and having hydroxychloroquine. Retrospective study, 500 plus patients, 241 users of hydroxychloroquine, again almost 70% reduction in the risk of CVD. Another study using a similar setting of patients reporting almost 68% reduction in the risk of cardiovascular events. In addition, the studies have shown there is improvement in lipid profile, reduction in total cholesterol, LDL and non-HDL, and studies have also shown that hydroxychloroquine has antiplatelet aggregation properties. Oxy trial is the ongoing, I think the trial has closed in December 2019. This is a prospective CV outcome study of hydroxychloroquine involving 2,500 patients. Patients have been given hydroxychloroquine in the dose of 300 milligrams per day for at least follow-up of 12 months, or the study will continue unless they have 350 CV events which are confirmed. And the primary endpoint is composite of death, myocardial infarction, hospitalization for unstable angina, and coronary intervention. Now, coming to the safety part, we know that this has been used for ages now for treatment of rheumatic diseases. It is different from chloroquine in that it has a hydroxyl molecule which makes it less permeable to enter to retina, and its ability is restricted. And because of this, the risk of retinopathy is much less. There is less than 1% risk of retinopathy for 5 years usage, or less than 2% risk of retinopathy after 10 years of usage. Current recommendation is that one should perform a fundus examination within 1 year of initiating hydroxychloroquine therapy, and thereafter you can follow up after every 5 years. The risk of hypoglycemia is increased if the patients are already on treatment with hydroxychloroquine, sulfonylureas, or insulin. It is contraindicated in patients who are pregnant or have in the lactation phase, contraindicated in children, elderly with decreased renal function, and so on. May lead to hypersensitivity, so patients with known hypersensitivity should not be given. So coming to the take-home message, hydroxychloroquine reduces A1C levels in the range of 0.9 to 1.3%, and can be given to all patients with type 2 diabetes who are inadequately controlled on at least 2 drugs, sulfonylurea and metformin, and patients. Thank you.
So thank you, Dr. Makkar, for the nice presentation and elucidating all the factors related to hydroxychloroquine. May I request my co-moderator, Dr. Shantanu Sen, to please carry on with the or start with the discussion about this particular topic and to introduce the next speaker and next topic. Dr. Shantanu Sen, please. Can I see Dr. Shantanu Sen? Okay, I think Dr. Shantanu Sen is not there. So I take this opportunity to ask Dr. B.M. Makkad one question particularly. This drug has been used as the third or fourth oral anti-diabetic drug. Can this drug be taken as the second line or the first line, means after metformin or even before metformin, especially in diabetic patients who are already having rheumatoid arthritis as the second line after metformin? Because rheumatoid arthritis patient must be taking this drug otherwise also. So in non-rheumatoid arthritis patients, can it be taken at the first line or second line drug?
Thank you, Dr. Sharma, for a very important question. I think, see, as of now, there is no approval for first line drug in patients with rheumatoid arthritis and diabetes for hydroxychloroquine. Doesn't make much sense also, because if you have diabetes, you have to first thing that you need to address is the insulin resistance. Because if you bring down insulin resistance, automatically you cut down the lipotoxicity and you also improve beta cell function. So metformin, I think, remains the mainstay and remains the first line therapy in addition to lifestyle interventions. As second line in patients with established, rheumatic disease, rheumatoid arthritis or, arthritic condition, you can certainly use this drug if the A1C is not in the range of 8% or higher, 8 to 8.5% or higher, because this will give you about 1% reduction in A1C in addition to improve the rheumatic condition also. But yes, sir, Dr. Panikkar, you want to say something, and your mic is muted. You have to unmute.
Dr. Panikkar sir, please unmute yourself.
Yes,
Yeah,
sir.
I have unmuted myself.
Yes, sir.
Excellent talk, Bridge. Excellent talk. One question. From your thing, you said, cardiovascular improvement means event reduction by 72%.
Yes, sir. This is observational data.
Yeah, but observe what events were reduced by 72%?
The risk of the myocardial infarction and cardiovascular mortality.
Because 72% means no drug to date has ever shown such a figure.
Sir, this is basically cohort of rheumatoid patients who were on treatment with the hydroxychloroquine and followed up for almost 17 years. And over that 17 years period, non-users versus users for more than 4 years of hydroxychloroquine. So there was hazard ratio was almost 0.3.
Okay. Another question. What you have shown is that it has a very nice effect on reducing insulin resistance.
Yes, sir.
And it is comparable to pioglitazone.
Yes, sir. There is a study which is head-on comparison with pioglitazone added to two-drug combination.
Yes. So could this be a substitute for pioglitazone, or could this be an add-on to pioglitazone?
No, not a substitute, because they have very different mechanism of action. So this acts on the by changing this intracellular pH and bringing down the degradation of insulin. So more insulin is available and improving the insulin sensitivity also. But pioglitazone is acting all together through a different pathway, which is by improving the transcriptional mechanism, RXR receptors, and improving insulin resistance at periphery. So it is two different pathways. I think they can be add-on.
No, all the inflammatory markers have shown reduction just like pioglitazone.
Yes, sir.
Adiponectin has increased just like pioglitazone used.
Yes, sir. Yes, sir.
So you could combine these two molecules.
Yes, I don't think
Get
there is any
additive
issue. And in fact, in my practice, I do combine. Sujoy, what is your take on this? Unmute yourself.
hydroxychloroquine is not one drug that I've used a lot, so therefore my personal experience with this drug in terms of an anti-diabetic is limited. But
Okay.
I have actually used it as an add-on, especially in individuals requiring very, very high doses of insulin.
Yes.
We particularly
I preferably use this drug when patients come with frozen shoulder. That is one condition where I definitely use this drug in all my patients, and it helps in improving the shoulder stiffness, brings down the glucose levels, improves A1C, and overall there is benefit.
So,
But I use it where you nicely pointed out patients who require high dose of insulin. There it helps in reducing the insulin requirement also.
so Dr. Makkar, since the CVOT trial is also there, and now in the COVID era, even the
It is in CV outcome trial is I think they must have closed the trial by now. I am not aware, but this year we are expecting the data from Oxy trial.
Now, the other thing which I want to ask is that since in this COVID era, it has also been used for this COVID treatment, and it has been propagated even by the US president. So what is the status of the FDA approval of this drug as an anti-diabetic medicine?
So this has been very funny situation. So this was approved and then unapproved and then again approved and then so this in India this drug has emergency approval from DCGI for prophylaxis of COVID also and management of COVID also. But the if you ask me what is the mechanism, I don't know. How it works, I don't know. But I think this has not been shown to have any kind of negative impact in the COVID. There have been so many studies, and the only issue was that there was increase in the QT interval when it was combined with the azithromycin. Now there were some studies which showed it. Other studies totally kind of disagreed with the observation that there is significant increase in QT interval when it is used alone, or it increased mortality. So even now, the recommendation for prophylaxis with hydroxychloroquine is there in India. US, I think, I don't know whether they have given again the approval for emergency use. I don't think they have given.
One mechanism may be.
May I just add?
Yes, sir.
One postulated mechanism of the hydroxychloroquine acting in COVID is by changing the pH intracellularly, it prevents the binding of the virus to the ACE2 receptor.
Okay.
So that is the mechanism. So it is the first stage of a COVID infection which can be prevented apparently. That's the theory behind it.
So that is why it is approved for prophylaxis also.
Yes.
Okay.
So as an anti-inflammatory drug also in COVID patients, and I think to some extent it looks after the inflammatory markers.
Can we stop here? I can ask Dr. Neelam to upload next lecture.
Yes, please. Please upload the introductory slide of Dr. Sujay Ghosh.
Thank you.
So thank you, Dr. Makkar. Thank you, Dr. Vijay Panikar. Our next speaker is Dr. Sujay Ghosh, and Dr. Sujay Ghosh will speak on the is it time to establish an elusive SGLT2 inhibitor therapy in Indian practice. Dr. Sujay Ghosh is Professor of Endocrinology at IPG MEA&R Kolkata, Editor-in-Chief of the Oxford Handbook Series, Southeast Asia Edition, Executive Editor, Thyroid Research in Practice, Indian Journal of Endocrinology and Metabolism, Associate Editor of International Journal for Diabetes in Developing Countries, Journal of Indian Medical Association, International Advisory Board member, worked as a clinical faculty in the University of Glasgow, several awards, including Best Research Paper Awards and many more, and published over more than 250 articles and contributed to chapters in books and co-author of 5 books. So I invite Dr. Sujay Ghosh to deliberate his talk in next 15 minutes. Dr. Sujay Ghosh, please.
Thank you so much, sir, for that kind introduction. I would first request the host to actually let me share the screen. You need to allow me to share the screen. The technical team needs to let me allow.
Host, please.
I request Team RX Events to promote Dr. Sujay Ghosh, sir, as the host so that he is able to share his screen.
Right. Sorry for that hiccup. Right. So I've been asked to speak on a very, very relevant topic. You know, we are talking about drugs in diabetes and management, and we are talking about possible benefits of drugs, but is our poor Indian patients actually getting that benefit? That's the major bit out of my talk. And we are all aware that, you know, we have been in this pandemic of diabetes for the last couple of decades. And if you look at where India is somewhere here, that there is again about an 84% rise in the prevalence of diabetes in the last decade. Very, very scary. And what's important is we realize that blood glucose control actually is very good in terms of microvascular disease. So when we are talking about nephropathy, neuropathy, and retinopathy, you've got the UKPDS trial, the ADVANCE, the VADT, and the ACCORD, all telling us that there is varying grades of benefits in terms of microvascular complications, less so perhaps for neuropathy, but much more consistently for nephropathy and retinopathy. But when it comes to the macrovascular or cardiovascular outcome trials, it's only the longer duration studies, for example, the UKPDS follow-up or the DCCT follow-up, wherein, and even the VADT follow-up, wherein you had some benefit in terms of non-fatal myocardial events. And we are also aware that in 2007, after the rosiglitazone fiasco of Steve Nissen, the US FDA mandated that every new anti-diabetic drug would have to undergo a CV outcome trial. And therefore, almost from 2013, you have a flurry of CV outcome trials which try to establish possible clinical outcomes, whether benefit or otherwise, you have of these medications beyond glucose control. And also, you know, we've realized that we cannot be just insulin sensitive centric or just beta cell centric, and cannot be just glucocentric, but we'll have to manage our patient holistically, and we'll have to think of all of the pathophysiological mechanisms by which diabetes probably occurs and can be managed. This is the ominous octet of de Franza. So we've moved from a glucocentric approach to a much more holistic, patient-centric, multiple risk factor targeting approach. And if you look at the traditional anti-diabetic agents, whether it's the sulfonylureas, the insulin, the alpha-glucosidase inhibitor, and even I can probably club metformin here, that these drugs are great in terms of glucose lowering, but in terms of other benefits, particularly cardiovascular outcome benefit, they probably have remained neutral and not able to reduce macrovascular disease. The only exception of metformin there is the UKPDS trial, wherein a small section of individuals did show some benefit with metformin. Now, coming to the new age group of drugs, that's the SGLT2 inhibitors, you can see there are 4 sets of outcomes that we are actually having data on for SGLT2 inhibitors. First, the composite of the major adverse cardiovascular events, that's the MI, the myocardial infarction, the non-fatal strokes, and all cardiovascular events. Then you specifically can even separate out and look at cardiovascular and all-cause mortality. And of late, we've realized that we've neglected heart failure as well as a major complication of diabetes, and of course, renal composite outcomes. And the 3 major SGLT2 inhibitors, dapagliflozin, canagliflozin, and empagliflozin, all have variable degrees of benefits, which all point almost to a class effect. Though after the publication of the Vertis CV trial, I'm not very sure whether it's entirely class effect. But you can see there's a trend towards benefit towards the MACE reduction, CV mortality, heart failure, hospitalization, and renal benefits. But we've got to remember that you cannot compare trial A versus B because of the different populations and trial designs. And like I said, the benefits seem almost to be moving in the same direction for almost all of those 3 major SGLT2 molecules. Even the renal composite outcomes, great results. We are waiting for the DAPA-CKD study. The top line news is already out. The credence is not included in this particular renal outcome composite in this particular slide. That's there in this next slide, wherein you can see, even in the credence, the EGFR benefit attenuation or the worsening of EGFR was there with the canagliflozin preventing or delaying worsening of EGFR. And that's similar to what you would find in the CVD real study. So therefore, it's on the basis of all of this that the AACE has actually come up with guidelines wherein one of the points that they make quite clearly is now that you should probably be thinking of using an SGLT2 inhibitor and probably a long-acting GLP-1 receptor analog independent of the glucose control. And then if you read the bigger document, it even says, even if the glucose is controlled by some other agent, you might wish to swap that agent with a GLP-1 or an SGLT2 if you're particularly concerned about ASCVD and chronic kidney disease. And this is the ADA-ESD combined guideline, the statement that came out. The section that's in magenta, if you can have a look at it, it's the updated section, which again tells us that if you have ASCVD or heart failure or CKD, probably higher up in the treatment ladder, you will have a GLP-1 and an SGLT2 inhibitor. So that's pretty dramatic. And we were listening to Dr. Makkar prior to me talking about metformin as well. But if you look at the European Society of Cardiology guideline, they've gone a few steps further. Whether it's justified or not is anybody's take, is that if an individual is drug naive and has ASCVD or multiple cardiovascular risk factor, you are even justified in starting an SGLT2 or a GLP-1 even prior to metformin monotherapy. And if what we are doing, for example, an individual is already on metformin, if the individual has ASCVD or multiple risk factors, please start the individual on an SGLT2 inhibitor or GLP-1. And this is Subodh Verma's paper in Lancet, which he talks about pumps, filters. And one of the things that he clearly mentions about is that when you're talking about the renal benefit and the heart failure benefit, that probably happens across the board, whether the individual has an underlying cardiovascular event or a problem or not. Whereas major cardiovascular events, particularly deaths, they will probably get prevented if you have already established cardiovascular disease, not because the drug works differently, but because probably the numbers needed to treat is less in such a situation, because higher the baseline risk, the greater is the absolute risk reduction. So we are in the middle of this pandemic, and the government of India, as well as IDF, talks about 7.25 crore people being affected by diabetes. I'm quite certain that that number is almost twice that number, given the fact that 50% of our population don't even get diagnosed with diabetes. And we in India are disadvantaged than the rest of the world in terms that it happens earlier in our population. It tends not to get diagnosed. We have very high comorbidities. Glycemic control tends to be very poor. We have certain genetic predisposition. There's a large pool of undiagnosed people and high complication rates. And almost 10% of all cardiovascular events in India occur before the age of 40. So that's again something which is dramatic. Indians have much higher cardiovascular risk. And that's probably because of what we call the thin fat Indian, low BMI but high body fat, high insulin resistance, poor beta cell function, and lower levels of adiponectin, high levels of leptin, inflammatory markers are high, and probably we have higher background inflammation that Dr. Makkar was talking about. And therefore, when you're talking about the cardiorenal benefits of SGLT2 inhibitors, it can probably provide us benefits at multiple levels, from the weight loss, particularly fat loss, glucose lowering, blood pressure lowering, and some degree of plasma volume contraction, which probably is going to help in the heart failure. But if you look at market data in terms of the IMS data, to look at the number of prescriptions, you can see that the SGLT2s are much lower down there in terms of comparisons to, say, metformin, sulfonylureas, or the DPP-4 inhibitors. It's not because the drug is not good, it's probably because of the cost issues that we are unable to use SGLT2 inhibitors in the kind of magnitude that we would want. So cost is the major limitation. Efficacy, whatever the clinical trials tell us, I think sulfonylureas and insulin are better in terms of efficacy of glucose lowering. And unlike, say, for example, DPP-4 inhibitors, we have certain safety concerns about SGLT2 inhibitor, and you've got to spend some time with your patient and talk to the patient about the problems. So in terms of the DKA, the AKI, the fractures, the dehydrations, and the infections, I think it's now very clear that if you choose your patient properly, DKA should not be a problem. And AKI is not at all an issue. And in fact, there are now studies to suggest that AKI might be reduced with an SGLT2 inhibitor. And in terms of the fracture risk, except for the CANVAS study, rest of the studies did not have any kind of signal to tell us that there's going to be increased fracture risk. So it was probably a outlier study rather than anything else. And we do realize that, if you're using it with, say, a secretagogue or insulin, you're going to increase the risk of hypoglycemia. From my point of view, the greatest risk of a use of an SGLT2 inhibitor or side effect is the GTIs. The genital tract infections are much more common. So we've got to re-educate our patients before we actually prescribe this group of drugs. And we've got to be a little bit careful in individuals with volume depletion. So if these can be managed, if you tell the patient about what to do about the polyuria, the volume depletion, about the genital hygiene, and where not to use the drug and avoid the drug or stop the drug in certain situations, and fracture risk is probably not that major an issue. So cost, if you look at the ADA guideline, it talks about if cost is an issue, then sulfonylurea and glitazones should be your drugs of choice. But at the bottom, you can see it does talk about consider DPP-4 or SGLT2 with low cost acquisition if cost is an issue. And if you go by our own RSSDI, ESI combined recommendations of anti-diabetic medication, you can see in most of the circumstances, SGLT2s do very, very well, except perhaps when you are thinking of very high blood glucose, extremes of age, or most importantly, the cost. So coming to one of the SGLT2 inhibitors and its costs and its efficacy, I understand Dr. Panikkar is going to talk on remogliflozin thereafter after this talk, but I just thought I would just point out the phase 3 trial by Dr. Maladharmalingam and et al. That has already been published, which kind of shows us that, as far as glycemic control is concerned, in terms of A1C, the fasting and the postprandial blood glucose, the drug seems to be doing reasonably well. And in this particular study, when compared to DAPA, side effect profile seems to be similar. And if you compare, because Dr. Panikkar is going to talk about INSPIRE, so I'm not going to talk about that, I'm going to skip that. And therefore, if you look at, ever since the introduction of remogliflozin, you can see that it has increased in prescriptions in leaps and bounds. And even though the data might not be as strong as that of empagliflozin, dapagliflozin, and canagliflozin, surely not that strong at all. But as far as the prescriptions it's gone up. So telling us that, cost is a major issue. And therefore, if you're able to produce a drug of the similar class with hopefully the similar kind of benefits, then it does make a difference in the Indian market. So to summarize, SGLT2 has ushered a new novel management paradigm. SGLT2 in India, type 2 diabetic individuals are at a much greater risk of cardiorenal problems, and therefore SGLT2 inhibitors which address both of these could be a good option provided people can afford it. The concerns with SGLT2s are manageable and can be preventable in most of the situations by good counseling. Cost barrier can be overcome by cheaper drugs. And in the Indian study that I showed, there has been equivalence in terms of glucose lowering and safety in that one particular study, though of course we probably need much more robust and bigger studies. So therefore, I shall stop there to take any questions. Thank you very much.
Thank you, Dr. Sujoy, for the wonderful presentation on the SGLT2 inhibitors. Now, may I find somewhere Dr. Shantanu Sen? Is Dr. Shantanu Sen there? My co-moderator? I think he's attending some other hall. So anyway, one important question is that whatever you have narrated about the SGLT2 inhibitors, is it a class or is it something different in each molecule?
Sir, had you asked this question about a month and a half ago, I would have confidently said it's a class effect. And whatever difference we have is because of the differences in the trial designs and the population that we are studying. Some question marks have been put into our minds with the VERTIS CV trial. I think had the Vertis CV trial kind of been similar to this, it would have made Remo's job much easier in convincing you and me that everything that is there, it doesn't matter what data you generated, the class of drug is doing the same. I'll be honest about it.
Right. So thank you very much. Is there any other comment from our other speakers and Dr. Mangesh Tivashkar?
Yes.
Yes.
Hi, good afternoon, sir. Good afternoon, Panikar, sir. Good afternoon, Sharma, sir. And good afternoon, Sujay. As usual, you are super duper. And in fact, it's always a pleasure to be, listening to you, rather. It's always a big experience learning all wise as Panikar, sir, is also there. So I'm going to have my treat today, sir. So it's like fine.
I would just like to comment, Sujay, that was a brilliant talk.
Brilliant, absolute
I
brilliant.
agree with you that Vertis has made things difficult. But Vertis did show heart failure benefits.
Yeah.
So on that count, I suppose that is a class effect. The rest of the thing we need to really wait and watch at what else comes out of Vertis in the further analysis. Let's see. But excellent talk.
Thank you, sir.
Now, thank you very much, Dr. Sujay. Now we proceed further and to listen to Dr. Vijay Panikar on the topic, which is again very, very important, remogliflozin, Indian real world evidence. And I would also like to listen to from Dr. Vijay the experience, evidence and experience, real world experience.
Absolutely.
Dr. Vijay Panikar is the Honorary Consultant Department of Endocrinology, Diabetes and Metabolism at Lilavati Hospital, Mumbai. Ex-Professor of Medicine, Somaiya Medical College, ex-Vice President, RSSDI, past Chairman, RSSDI Maharashtra Chapter, past President, College of Physicians and Surgeons of Mumbai, Organizing Chairman, RSSDI National Conference in Mumbai in November 2020. He has publications to his name. He has written chapters in textbooks and medicine updates, and a pioneering work on triple drug therapy and low-dose pioglitazone 7.5 milligram in clinical practice. Co-author RSSDI recommendations for diabetes management and authored RSSDI guidelines for in-hospital management of diabetes 2016 and developed an app for the same. So, Dr. Vijay Panikar, sir, please.
Sharma sir, just give me a liberty of speaking a little bit on in-hospital management hyperglycemia. The quality of that, I would say, paper that sir has come out with and the simplicity he has handled it was outstanding. Outstanding is the smaller word. And not only that, I'm still using that app, sir. There are little hitches, but still my residents are using that app. It's been really wonderful effort by Jimit and sir and entire team.
Thank you, Mangesh.
Sir, please. May I request the organizers to please share the screen of the presentation of Dr. Vijay Panikar, sir.
I believe they must have recorded it.
They have recorded.
They must have recorded it. They have to play that.
Talk already.
Yes, sir. I request Team RX Events to share the screen.
Hardik, are you there around?
Hello, sir.
Hardik, sir का वीडियो प्ले करो यार.
एक मिनट.
हाँ. तर काय म्हणताय सर तुम्ही? हाऊ आर यू?
So far so good.
Good to see you, sir. किती दिवसांनी मला बघायला मिळालं तुम्हाला ॲटलीस्ट. चालू केलं मला असं वाटतं.
ESD is pushing up the SGLT2 right up the ladder. After metformin, it is SGLT2. You look at the ADA ESD guideline.
The slides are not visible. Yes.
After metformin, it is SGLT2 or GLP-1. But look at the ESC guidelines. They say if you have a drug-naive patient and he has got an atherosclerotic cardiovascular disease, you can straight away start SGLT2 on day 1 without metformin. And if the patient is already on metformin, again SGLT2. That's what is happening with SGLT2. And if you look at the SGLT2, the global journey, a lot of SGLT2s have come in the market. And finally, we had remogliflozin, which was launched in India. Let us look at the clinical development and the real-world utilization of this new molecule. Just to look at SGLT2, the historical review. Basically, it is...
Dear friends, ladies and gentlemen, I appreciate the great gesture of Professor Sunil Gupta inviting me to talk on.
There is some overlap. I don't know why.
Check out. Maybe
He is speaking.
clash. Or otherwise, sir can speak extempore.
Sir, we would have loved to listen to you live.
Yes.
Give me the screen share, I will do it.
Yes.
Organizers, please share the screen of Dr. Vijay Panikkar, sir. Give him the screen sharing.
Wonderful virtual conference. The topic given to me is very relevant to today's findings. Remogliflozin. It's a new kid on the block, a new SGLT2 which has been launched in India. Let us look at the Indian real-world evidence for it. All over the world today, all the associations, whether AS, ADA, ESD, is pushing up the SGLT2 right up the ladder. After metformin, it is SGLT2. You look at the ADA, ESD guideline. After metformin, it is SGLT2 or GLP-1. But look at the ESC guidelines. They say if you have a drug-naive patient and he has got an atherosclerotic cardiovascular disease, you can straight away start SGLT2 on day 1 without metformin. And if the patient is already on metformin, again SGLT2. That's what is happening with SGLT2. And if you look at the SGLT2, the global journey, a lot of SGLT2s have come in the market. And finally, we had remogliflozin, which was launched in India. Let us look at the clinical development and the real-world utilization of this new molecule. Just to look at SGLT2, the historical review. Basically, it was found from the naturally occurring from apple bark tree. And it showed that it can cause glycosuria and reduce the blood glucose level. But this fluorosin could not be really converted into a drug. So a prototype, it served as a prototype, and various O and C glucoside molecules were created to improve its stability and selectivity. Now, with the O glucoside, you have the remogliflozin and sirgliflozin. C glycoside are on all our currently available SGLT2s other than Remo, Cana, DAPA, EMPA, and even ertogliflozin. And this O glucoside and C glucoside is what makes the structural difference in the impact of the drug effect. Now let us look at how all SGLT2s interact with the molecule. This is a glucose molecule and this is a SGLT2 molecule. Every SGLT2 molecule has two parts. The glycone part, which is glucose, basically identical to glucose, and the aglucone part, and that is joined by a bond. So the glucone part in all the SGLT2 molecules is a glucose. It's perfectly a glucose molecule, and that is what binds with the receptor. And this bonding is what creates the pharmacodynamics of the drug. The O glucosides are these two, and the C glucosides are all the other conventional or the already present SGLT2s. When you have the O glucoside, what happens is that O glucoside bond can be lysed by beta glucosidase, and hence they have a shorter half-life because of this bond which can be lysed by beta glucosidase. But the C glucosidase does not get remodel or doesn't undergo anything. So they have a longer half-life. That's the basic difference. So if you have a remogliflozin and you look at its plasma concentration, 12 hours, it really dips down. So it has to be given as a BD dose, and this is because of the bonding. Over the years means it's just about a year that Remo has come into the market, but you can see the market share of the molecule really going up and up. There have been a lot of development programs here from 2017 onwards. A lot of studies have been done. I won't go into the details of the study, but now from 19 to 20, continuing clinical development, you have a lot of studies which are in the pipeline here, which I'll just allude to them a bit there. A lot of publications have come in international journals across the world on the efficacy and safety of remogliflozin. And these are the evolving evidence of remogliflozin. These are the trials which are underway. Revolution, REMIT-FF, INSPIRE, INSPIRE-M, and so on. Revolution is basically a prospective real-world study, which would have almost 10,000 patients, and it's a DGCA-approved review. The REMIT heart failure, HF, that is basically remogliflozin in the management of Indian type 2 diabetes in heart failure. Sample size is 250. There are 10 study sites across India, and it is in the pipeline. You have REMIT-GV to look at the glycemic variability of remogliflozin, and again, sample size 75 patients, 1 or 2 centers. You have the ADOPT study, which is Asian Diabetes Outcome Prevention Trial, 2,400 sample size, 5 Asian countries and 600 patients from India. So it is a multinational study which is being planned. So this is the timeline for the evidence generation, which we have just discussed. Then we have INSPIRE and INSPIRE-M. What is INSPIRE? It is Indian type 2 diabetes patients of remogliflozin, safety and effectiveness, and it's a real world experience. They have looked at glycemic assessment, metabolic assessment, and so on. Now let us look at the glycemic assessment. They looked at HbA1c, fasting and postprandial glucose. Basically, the cohort size was 28,000. But in the final analysis, they have only taken 5,452 patients who had all the data required for almost 3 to 6 months. So looking at the data from this 5,400 patients, if you look at HbA1c, over a 3-month period, there is a decrease of 0.95 HbA1c, which matches with practically all the other SGLT2 molecules, which vary from 0.8 to 0.1. The fasting plasma glucose comes down by 42 milligrams, which is again matching all the other SGLT2s. The postprandial comes down by about 69.1. Now, if you look at the body weight and the BMI, the body weight over 3 months comes down by about 2.6 kg. The BMI comes down by almost 1. Systolic, diastolic BP and hemoglobin, mild reduction, which is keeping in track with all the other SGLT2s. So there are very similar findings as far as the weight, BP, systolic, diastolic is concerned, and HbA1c and so on. Efficacy observed with other real-world evidence, it's again matching. When you look at DAPA, CANA, EMPA, and REMO, they almost match, not really statistical significant difference. Now, this was a study which we had sent to the EASD for the presentation. This is a real-world study from our center where we looked at 3,294 patients who are on remogliflozin, of which 1,000 had completed almost 1 month was done by about 2,800. 3 months follow-up was 2,200 and 6 months of 1,945 patients. And what did we find? The fasting blood glucose about at the end of 3 months comes down by almost 50 milligrams, which was in keeping with the other studies which are shown. The postprandial again comes down by about 60 to almost 60 milligrams. HbA1c by 1.2%. The total body weight by about 1.5 kg. in 6 months, 1.23 kg in 2 months. The serum
Good evening, everybody, and I welcome you on to this nice symposium that has been arranged. And as the opening batch,
क्या हो रहा है?
It's almost getting a grip, but super duper flow, sir.
Hardik, what is happening?
But,
Anybody from the organizing team can listen to us?
Yes, sir.
What is happening, please?
थोड़ा सर टेक्निकल थोड़ा.
But this is 3,200 patients is a super duper data, sir. Outstanding data that has come out. And almost similar glycemic efficacy with almost similar weight reduction.
Very similar.
Absolutely. Outstanding data this is.
In the times to come, it is going to be number 1 SGLT2 inhibitor.
Yes, Sharma sir, absolutely, you're right. And we are also all prescribing that.
And the another good thing is that comparable side effects, comparable efficacy, and the cost. If you compare the cost is too low.
It is not too low.
Twice in a day. Yes, it is. Twice in a day. But sir, dose to me, what dose you use? Is what 100 milligrams twice or 50 milligrams twice?
BD can be used. 50 milligram BD gives you an equally good effect.
Okay.
Yes, now they have corrected it.
Yes.
I think this was done with the fear of there should not be any technical glitch. That is the reason why this recording was done. Now to be exactly ulta ho raha hai, Hardik.
Vijay, are you there? Dr. Vijay Vishwanathan.
Yeah, I'm there, sir. I'm listening to you.
Hi, good evening, Vijay. Hi.
Nice talk.
Hi.
A nice talk. Yeah, it has stopped in between. I think that is the nice part of it.
No, that is because Vijay has just joined. So you know everything, the whole.
60 milligrams. HbA1c by 1.2%. The total body weight by about 1.5 kg in 6 months, 1.23 kg in 2 months. The serum creatinine showed a slight elevation in this period here. Now this is again consistent with all the SGLT2s. Every SGLT2 will show an initial increase in serum creatinine, which stabilizes later. The initial drop in eGFR, which again stabilizes later. And this is also following the same trend. So eGFR, there is a reduction. And looking at the clinical safety parameters, basically genitourinary infections count for the majority of all the infections and complications that you see with this drug. Vaginitis, balanitis, urinary tract infection, polyuria. One of our patients had loose motions, which was distinctly because of remo and some vague discomforts. So remogliflozin has shown a clinically significant reduction in HbA1c, fasting, postprandial glucose, and the clinical efficacy is seen quite early in the patients, just like all other SGLT2 molecules. It is being well tolerated by patients with no major safety concern identified. Again, I would say it matches all the other SGLT2s to the T. The clinical response is at par with other SGLT2s currently available in the market. Thank you. Thank you very much for a very patient listening.
Thank you, sir.
Yes, Sharma ji.
Yes, sir. Thank you very much, sir. Thanks a lot. So I invite any questions if anybody has any questions, because there is no question.
Sir, I have a question.
Yes.
Sir, could this loose motions that your patient had in a study? Was it basically because there is an additional SGLT1 also, possible action of SGLT1 involved there, or
fact,
is
that's what the thought process. And this lady, she had severe loose motions. We stopped the remo and it disappears. And we again gave her a challenge and it reappears.
but it was for plain remogliflozin, or it was with metformin as well?
Plain remogliflozin.
Okay. So that means that it
No, she
definitely.
had metformin in the background. But
Okay.
remo was added and she developed loose motions.
Okay.
We stopped remo, the loose motion stops. You re-challenge with remo and classically the same loose motion starts. It was absolute. So I can vouch and say it is because of remo. And
Yes.
possible explanation, like you said, is the SGLT1 maybe.
Yeah, maybe getting triggered. Yeah, maybe she may be sensitive. And if it is so, then that would be another additional benefit.
Yes.
Yeah.
Right. So thank you very much, sir.
Welcome,
And
sir.
I thank all the speakers and everybody who has attended. And my special thanks to Dr. Mangesh Tiwaskar for taking a lot of interest in the discussion and giving many insights also. And now I hand over the session to the organizers. Thank you very much.
Thank you, Sharma ji. Thank you for an excellent comparing.
And stay safe. Stay safe, sir. Be safe and stay safe.
Thank you so much, dear respected faculty. We are honored to have your scholarly presence in the Hello Diabetes Academia, and we highly regret for some technical issues that have been looked right now. So for the next session, invite Dr. Narayan Devgaonkar sir from Nashik. Is he there online?
I did not see him.
He's joining, I guess. And I invite Dr. Vinod Mittal sir from Delhi.
Yeah, good evening.
Hi, good evening, Mittal sir. Good afternoon.
Yeah,
How are you,
good
sir?
afternoon. So how are you, Mangesh? Long time.
Long time, sir.
Good afternoon, Dr. Vijay Panikar, sir. Nice seeing you after a long time.
How are you?
Great. So I think it is Dr. Mangesh, your talk first.
I am not sure. It's like what? Yeah.
Yes.
Okay. Maybe possibly. Yeah.
It's your talk only. Huh? It's diabetes and anemia.
Yeah.
Okay, so I think we move ahead. So it's my proud privilege to introduce Dr. Mangesh Tiwaskar, who is a close friend of mine, but at the same time, he's been holding very, important post in diabetes organization as well as API. And he is got a keen interest in diabetes, and he's got gold medal in his MD. And he is a member of governing body of API, general secretary, and got a vast experience. So I don't think we need anything more than this. I would request Dr. Mangesh to please start with this deliberation.
Hardik, is it that we are going to play the video, or am I going to talk extempore with the slides, with the screen share?
Yeah, please, share the slides of Dr. Mangesh.
Yes, sir.
That should be an automatic process. I don't think a chairperson or speaker should ask for it.
What I'll do, Hardik, is this, that because there is some problem with the full screen issue.
But it never happened, Zoom is generally, we have very good, even bigger conferences like cardiometabolic conclave and other.
Yeah. So,
okay.
Hardik, if you don't mind, shall I play my slideshow here or something like that, or you will be able to do?
Yeah, it's there.
Audio is not coming through.
Any issues there?
Just 2 minutes, sir. 2 minutes.
Okay.
So we are just starting your speech. So it's already started in the hall. For your reference, we are also playing it here as well. So Team RX Events is just sharing the screen with the audio as well.
Hi, good afternoon, everybody, and thank you, Dr. Sunil Gupta and Hardik and team, for giving me this opportunity. And I will be speaking to you today on anemia and diabetes. Accept my big thanks on the day of Guru Purnima. I am recording this session. So let's understand why we should know a bit on anemia and diabetes and why it is important. So in a quest to do that, I had an opportunity to be a part of the position statement team, which published through Indian College of Physicians a position statement on anemia and metabolic syndrome. And when we were working on this position statement, we realized that in India, we have a huge amount of anemia which is present. Globally, around 2 billion people are anemic. But in India, 50% of population is anemic. And every 9 out of 10 women are anemic. Now, that is significant. And India forms the largest Southeast Asian country to inhabit anemic population. And the amount we spend, especially, United States spends on managing the anemia and related diseases is around $2 billion every year. Now, if you really look at India as a healthcare burden population, you will see that there is a huge burden of stroke, obesity, non-communicable diseases like diabetes, hypertension, heart diseases, dyslipidemia, malignancies. But when it is superadded with anemia, the outcomes, they really become bad. So let's talk about anemia and diabetes. And this will be my attempt to decrypt the nexus today for you guys. And I feel always that anemia and diabetes is, as usual, in general as anemia, is under-recognized, under-diagnosed, and under-treated. It not only impacts the monitoring, but also adds to complications, which will ultimately lead to increase in morbidity and mortality. It also contributes in developing and progression of vascular complications. And many a times, anemia and diabetes can be drug-induced. So we need to be very careful, especially when the patients are on with drugs like pioglitazone. Now, there is one more specialty of anemia and diabetes, that it appears very early sometimes in the presence of kidney disease. But when it comes to diabetes-related kidney disease, anemia could be one of the first manifestations, even before the eGFR starts falling or even before the serum creatinine goes up, anemia starts appearing. So I just was wondering, let us look at the normal physiology of red blood cell production. And this is going to mesmerize you. This is a data from DeGruchy and Williams, one of the textbooks of hematology we all read in our MD times. And look at the amount of red cell production which is happening every day. 2 million cells are manufactured per second. Now this I am talking about only red blood cells and bone marrow. 120 million cells every minute, and more than 173 billion cells, red blood cells, are manufactured every day in bone marrow to give us a hemoglobin which has to be in a normal range of 15.7 for men and 13.8 in women. And the Kidney International and the Hematological Association of India and World Health Organization gave us the diagnostic criteria for diagnosing anemia as hemoglobin less than 13 grams per deciliters in males and less than 12 grams per deciliters in women, with hematocrit less than 39 and 37 in men and women respectively. And remember that, mind well, that with each 1 gram fall of HB, we have multiple cardiovascular adverse outcomes. May it be left ventricular hypertrophy, may it be left ventricular dilated cardiomyopathy, a systolic dysfunction, a congestive heart failure, or ischemic heart disease, or cardiovascular disease-related mortality. And the mechanisms are obvious. And in your flow chart here, you can see that anemia, which will lead ultimately to a myocardial damage, either via increased cardiac output, volume overload, or it can cause myocardial hypoxia basically because of tachycardia. Now, this myocardial hypoxia will ultimately lead to excessive RAS stimulation, and also volume overload will cause the left ventricular hypertrophy. In addition to that, because of excessive RAS stimulation and left ventricular hypertrophy, there can be a hypertension or vice versa, which will ultimately lead to either the coronary heart disease or the excessive RAS stimulation and the left ventricular hypertrophy will cause myocyte loss, progressive fibrosis of the cardiac muscles, which will ultimately lead to heart failure, which can be one of the added complications for the causation of heart failure and diabetes. And more significant duration of time, the patient stays anemic below the permitted level of 11 grams, you will realize that the patients, they start becoming bad to worst. And the risk of anemia in diabetes is very high. It's like 2 to 3-fold high. And the risk augments with the development of anemia. And as there is anemia, as you can have macrovascular complications, you could have macrovascular complications as well. And I don't want to go into the details of the flow chart because of the want of time, but you can see here that diabetes and hyperglycemia ultimately will contribute to anemia in multiple ways. But one of the most talked about ways is the cytokine way. There is an increase in the inflammatory cytokines, and we all are in COVID times and we know what our inflammatory cytokines are, which will ultimately cause blunting of erythropoietin production, which will lead to reduced erythropoiesis and will reduce down the RBC lifespan. And also the inflammatory cytokines will cause dysregulated iron homeostasis.
I believe it got stuck. Hardik
is one of the hormones or enzymes produced in liver.
Speak live if it is arrested. We could have delivered live.
Yeah. Anyone from RX events?
Yes, sir.
What is the problem going on? There's something very peculiar this time.
Some technical issues.
Yeah. Even I can't see the screen properly. You are, even in the halls, it's not seen properly.
I can speak live as well, as Sanjeev said. Or otherwise
live could have gone better.
Better, I believe, yeah. And with this fear of हार्दिक क्या चल रहा है भाई, क्या challenge है? I can start from where we left. Shall I share my screen, Hardik?
I think that could be a better suggestion.
Yes,
I believe so. Screen.
I think the speaker should be able to share the screen. That is the best way.
Yeah, that's the best way, I believe.
Yeah, because then you can handle. You have a full control and.
Yeah.
Usually below 30. Clinical manifestations of anemia, we are all aware about it. How do you diagnose? Usually the easiest diagnostic test for the anemia, especially in diabetes, is to just do a serum ferritin level. Because if the serum ferritin levels, usually if it is above 100 nanograms per ml, it is anemia in diabetes. And if the serum ferritin levels is less than 30 nanograms per ml, that suggests that there is a presence of iron deficiency anemia. There are a few other tests which you can carry through. I don't want to go into the details about it. They are on your screen. Bone marrow is not a routine indication. unless until you suspect that there is a myelodysplastic syndrome or hematological malignancy, you may or may not take a chance of doing a blood bone marrow. So take your call. Now the challenge is, how do you differentiate between an iron deficiency anemia and anemia of the chronic disease or anemia of diabetes when they come together sometimes? So that's what I told you. The easiest test to do, apart from all the tests which are there on your screen, the best test to do is just to do a simple serum ferritin level. Where there is an anemia of diabetes or chronic disease, ferritin levels will be normal or increased. But whenever there is an iron deficiency anemia, ferritin levels can be reduced. But the challenge comes when these two come together. That means anemia of diabetes and iron deficiency anemia, when they come together. And in quest to address this question, we also published on diabetes and anemia in a Southeast Asian region position statement along with Dr. Sanjay Kalra and Dr. Manisha Sahai in diabetes and metabolism. And this is what we have suggested. Those people, those who are interested in, can go through this paper, and we have suggested the approach, a complete algorithm of how to approach the management and the diagnosis of anemia in this situation. But the gist of the story is this, that in an anemia of chronic disease or diabetes, look at hemoglobin, which is hardly low. If you get a severe anemia in diabetes, it is unlikely because of diabetes. It could be a superadded iron deficiency anemia. Of course, retic count and the mean corpuscular hemoglobin might help you to clinch the diagnosis. Treatment is usually of the underlying cause. There could be the choice of blood transfusions, erythropoietin injection, or treatment with folates. Remember that when it comes to IDA plus ACD, that is anemia of diabetes and iron deficiency anemia, iron therapy is very effective. But then there are certain caveats of this. We need to find out whether there is additional presence of infection or malignancy which is causing anemia. And if the ferritin levels are above 100, iron therapy is contraindicated, remember, because it can cause iron toxicity by a situation which is called as Fenton reaction, which is usually triggered by TNF alpha. What are the therapeutic options? Along with iron therapy, you can use erythropoietin. But remember that erythropoietin should not be given when hemoglobin is more than 13, because there are no additional benefits except that it can cause a reduction or haltage of left ventricular hypertrophy progression. There are few emerging therapies which are there, like anti-cytokine therapies, ion chelation therapies. There are hepcidin antagonists which are tried. Recombinant erythropoietins are also tried. A combination of erythropoietin plus iron therapy is on the board. Ferroportin agonists are also tried. So to conclude, ladies and gentlemen, anemia is a modifiable risk factor for cardiovascular mortality and morbidity in diabetes. When it comes to diabetes plus CKD, anemia could be one of the first presentations, so be vigilant on it. Regardless of eGFR, anemia occurs very frequently in severe diabetes in comparison to diabetics. So we need to screen patients regularly. Guidelines recommend to maintain hemoglobin in between 11 to 12. Correction of hemoglobin more than 13 grams have been proved to have no benefits.
Rightly said, is the GDM, which is the mother of NCD in.
That's okay.
Yeah.
We are almost through, I believe, so it's okay.
Great talk, Dr. Mangesh. Should we have the question answer at the moment, or we have at the end of the session?
Whatever you say, sir.
I think you can
Okay,
talk by talk.
Thank you very much.
Okay, so I
I
would like
believe
to.
Vijay is there, Sanjeev is there. So
Okay, so I would like to ask you one question, Dr. Mangesh.
yes, sir.
Like in diabetes, as you said, there is a CKD also, anemia, iron deficiency, everything is going simultaneously. So it's very difficult to find out whether it is really iron deficiency or it is so. One is, what is the role of HbA1c in patients with CKD because of anemia? Is it false negative, positive, and should we rely on this, or should we go for other marker?
No, in fact, that is one area which has been always debated, Mittal sir. And we all also know that HbA1c can be sometimes falsely high in a situation where there can be a possibility of an anemia, especially if it is a severe anemia. But what is the specialty of diabetes related erythropoietin deficiency leading to anemia is this, that usually in a non-diabetic CKD, usually the anemia and the erythropoietin deficiency starts occurring after the eGFR falls below 45. But in diabetics, the anemia can and the erythropoietin deficiency can even start at the eGFR of around 60 and below. Secondly, and the most important thing is this, that here are the situations where you might also think about doing some short-term markers, like especially fructosamine or 5-HT. So all these things can be possibly tried, because HbA1c may not be a very smart thing to do in this scenario, and especially in the presence of severe anemia, I think we should take it with a pinch of salt.
Yeah, so you are absolutely right. Actually, what is recommended is in patients who have severe, CRF, there instead of glycated hemoglobin, glycated albumin may be a good choice. One, and best is a self-monitoring of blood glucose. That can be more reliable because these people have erratic meal habits, and so HbA1c overall glucose monitoring may not be that important as a daily basis monitoring.
Yes,
yeah. And what is the best iron preparation to be given to these people if there is iron deficiency?
Yeah, before I answer your question, Panikar sir wants to say something, sir.
Yeah, I just wanted to make a point. Excellent talk, Mangesh. Basically, whenever there is iron deficiency, you will get a higher HbA1c.
Correct.
And there is enough documentation of that. And study has been done to show that in Indian population, you will have a slightly higher HbA1c because of iron deficiency. So ferritin, what you said, is the correct test to do for it. And if the iron is corrected, then you will get a proper HbA1c. I'm not talking of CKD, I'm just talking of anemia.
Yes. And as far as the proper iron therapy is concerned, so there are 2-3 good iron preparations which are available. But again, with a big caution, that overzealous correction of iron in presence of diabetes or in anemia and metabolic diseases can be a challenge, and sometimes can lead to severe Fenton type reaction or iron toxicity. So we need to be a little careful. First diagnose and establish that there is an iron deficiency additionally. Then only go for the overzealous or probably the corrective therapy for the iron replacement therapy. And you have got, there are 2-3 preparations which are also available now. It is, iron polymaltose sorbates are so many combinations and compositions are also available. Iron zinc preparations are not too much popular nowadays, but then we do have these polymaltose combinations which are available and which can be easily administered, and the tolerance and acceptability is excellent with minimum possible GI side effects.
Yeah, sir, already we are running late. Can we go ahead with the next speaker?
We can.
Yeah, we can.
Yes, sir.
So
Thank you, sir.
away,
Thank you so much.
You can, put the. Okay, so we move to the next presentation by Dr. Vijay Vishwanathan on painful diabetic neuropathy, and he is a renowned diabetologist of India, and he's got a lot of work in neuropathy, and he's received many awards and honors, and he's been into practice for more than around nearly 30 years. And he's been awarded fellowship of Royal College of Physicians, and his field of interest are basically foot and diabetes, kidney disease in diabetes, and diabetes in patients with tuberculosis also. Yes. So with this, a small introduction, I will request now Dr. Vijay Vishwanathan to start with this deliberation.
Sir, I had the honor of being there when Vijay was honored with Dr. Vivian Fonseca best paper in diabetes and tuberculosis that happened in ADA Boston. It was one of the most proudest moments for all of us.
Thanks, Mangesh. I think we are going to have the slides, no? Because I've already done my recording.
Yes, I don't know.
So just wait for a couple of minutes, yeah. I can't hear the voice, no?
There is some challenge, there is some technical glitch which is there.
Hardik or Aman, Shlok.
Voice clear.
They can allow me, I can talk.
I believe that you can do straight away, Vijay. That is the best way to start, I believe.
But I think the audience are able to hear.
Yeah.
The talk is going on, but
Nobody is able to hear.
Absolutely. No audio, no audio, no audio.
If faculty cannot hear, we don't know audience is listening or not.
Now you'll be able to hear but not see.
Yes, that is a challenge.
Is say something like 36-fold higher. So this is a very important point because neuropathy is not about just pain, but it is also about amputation. So if you have neuropathy, you have a very high risk of amputation, particularly if you have a deformity or a previous history of ulceration, so on. Though this is the fact, neuropathy is often forgotten as an important diabetic complication. It's only when the patient starts complaining to us about severe pain and burning sensation in the night in the feet that we really realize that the person has got diabetic neuropathy. But to make a diagnosis simply by a diabetologist, to make a diagnosis of diabetic peripheral neuropathy or diabetic polyneuropathy, you should have diabetes and a history of sufficient chronic hyperglycemia for some time. And this is very characteristic, a characteristic pattern of a symmetrical distal lower limb sensory motor polyneuropathy. So sensory nerves are involved, motor nerves are involved. It's predominantly the lower limbs, it's predominantly the distal part, and it's predominantly symmetrical. So these words are very important. And usually there will be an association with, say, microalbuminuria or retinopathy and so on. Now, when we talk about pain, you should understand that it is due to involvement of what is called the small fiber neuropathy. There's also a large fiber neuropathy which results in absent reflexes and decreased vibration position sense and so on. But the pain is predominantly due to the involvement of the small nerve fibers. Now, this is an excellent classification for diabetologists from Thomas Dick, who's a neurologist in the UK. Now, what we need to understand, we physicians and diabetologists need to understand is, there's a stage 0 where the person has no neuropathy, no symptoms, and when you test, there may not be any abnormalities. But this is the important stage 1 when we diabetologists or physicians should be aware of and test and find out. And that is asymptomatic neuropathy, where when you test, you will definitely find 1 or 2 abnormalities of neuropathy, but the patient will not complain of any symptoms of numbness or positive symptoms like burning sensation. Stage 2 is when most of our patients tell us they have pain and severe neuropathy. So stage 2 and 3 is when the patients actually tell us they have severe pain in the feet and they can't sleep. And when you test, there will be 2 or more abnormalities. But this is a bit too late. Therefore, my request is most of the diabetologists or physicians treating people with diabetes should try to diagnose this diabetic neuropathy at a very early stage, in stage 1. Now, having said that, this was one of the earliest studies from India, which we did from our center in Chennai, where we published in Neurology India in 2004 that even in the stage of impaired glucose tolerance or pre-diabetes, about 19.3% of the pre-diabetics have evidence of neuropathy. We did the study using the nerve conduction velocity, and we found that mostly the sensory nerve is involved. And it was found that about 19% of people had evidence of neuropathy even at this stage of pre-diabetes. So don't expect neuropathy to occur only in people who finish 10 years and 15 years of diabetes. You can get it quite early. Now, when we talk about the evolution of neuropathy, of painless neuropathy, which is the more dangerous one, about which I will make a passing mention at the end of my talk. Now, talking about the treatment of diabetic neuropathy, we must understand that most of the drugs which we use for neuropathy today in India are all agents which are aimed at providing symptomatic relief to the patient. And I'll talk about it 2 or 3 slides later. However, we should understand that none of these agents have any bearing or any influence on the natural history of neuropathy. It's only some agents like alpha-lipoic acid and gamma-linolenic acid which have been shown to alter the natural history. And of course, the most important thing is diabetes control, for which I'll tell you in the next slide or in the next 2 slides later. Now, don't assume that all neuropathies which you've seen a person with diabetes is due to diabetes. It could be due to factors like thyroid disease. It could be because of even a bronchogenic carcinoma. It could be the effect of alcohol, HIV infection, or if the person is taking anti-tuberculous drugs, it could be due to that. Therefore, please rule out thyroid disease, hypothyroidism, and other relevant causes for neuropathy, and don't just think of diabetes alone. Now, when do you start treating the pain? Do you wait for the patient to say, I have severe burning, and then you start? So there's no real clear guidelines when you initiate. Some patients can't tolerate even minor pain, so we might have to treat at that stage. But the important point we need to understand is that there is something called peripheral sensitization and central sensitization. Therefore, we have drugs which can work on the central sensitization or on the peripheral sensitization. And this is a simple diagram showing you how each of the drugs work. If you take drugs like the topiramate or carbamazepine, they are sodium channel blockers. If you take drugs like pregabalin, it works on the calcium channel. If you take drugs like gabapentin, it works on the GABA receptors, and it is also working on the calcium channel. And then we have drugs which work on the central nervous system, and then we have drugs which work locally on the small nerve endings, which are mostly applied onto the foot. As I told before, we know that for every 1% reduction in HbA1c, you can expect a good reduction in the neuropathy, retinopathy, and nephropathy microvascular complications. The maximum benefit, in fact, or the immediate benefit of controlling diabetes is seen in the microvascular complications like neuropathy. Now, when we come to the treatment of painful neuropathy, we have an array of drugs. So generally the question is asked, which drug do I use? So it is a personal choice or your personal experience, but in general, this good publication from Dan Ziegler from Dusseldorf in 2015 gives you some guideline. For instance, if you have a prominent sleep disturbance, for instance, because of the pain, gabapentin might be better. If you have anxiety along with prominent sleep disturbance, it could be even pregabalin. If you have depressive, anxious state for the patient is anxious and depressed, duloxetine might be better because it is a good antidepressant. Whereas if you don't have anxiety, it's just depression along with the burning sensation and so on, you could be using tricyclic antidepressants. Now, these are the first line agents, initial therapy. Now, when one of those agents is not effective by itself, you can think of combining any two agents. You usually don't combine the two calcium channel blockers. You could use one of this from the blue shading and the green shading and so on. Therefore, you can use combination therapy if one of these drugs is not effective. What about the recommendations about which drug? So, as you can see that these are a number of organizations like the AACE, AAN, American Academy of Neurology. For everybody seems to be voting pregabalin as the number one or number two choice. Therefore, the pregabalin seems to be a favored choice. But having said that, as I said before, to change the natural history of the neuropathy, you have elegant studies from, again, Dan Ziegler and Dusseldorf, who showed that if you use alpha-lipoic acid, and we had published a study 20 years ago in Chennai, by using alpha-lipoic acid, you can actually achieve good pain reduction and also a meaningful improvement and prevention of progression of neuropathic impairment. Therefore, there are studies which have compared it with placebo as this one, and also there have been studies which have used methylcobalamin along with alpha-lipoic acid, and you can see that when you combine the two, the effects are much better than when you use a methylcobalamin alone. Moreover, methylcobalamin is useful only in people who have real vitamin B12 deficiency. Therefore, you need to check and then give. The last 1 minute, let me talk about painless neuropathy. Now, these are patients who had loss of sensation and had amputation. And I told you in the first slide, if your risk of amputation is very high, if you have a previous history of ulceration, or if you have deformity and so on, and if you get injured. And of all the factors which...
So, hello friends, and I welcome you.
Vijay, we have gone in the second hall.
Yes. In the first hall, we are in the second hall.
Now we shifted to second.
We'll wait for 30 seconds and see.
Yeah.
We have no choice.
So can you finish?
Methylcobalamin is useful only in people who have real vitamin B12 deficiency. Therefore, you need to check and then give. The last 1 minute, let me talk about painless neuropathy. Now, these are patients who had loss of sensation and had amputation. And I told you in the first slide, if your risk of amputation is very high, if you have a previous history of ulceration, or if you have deformity and so on, and if you get injured. And of all the factors which produce an ulcer, a neuropathic ulcer, diabetes is the most important, and it produces a number of changes as a result of neuropathy, like the muscle wasting and so on, which produce a neuropathic ulcer. There are devices like the one we tested in 2001, where we used a 128 Hertz graduated tuning fork, called the Rydell C for tuning fork. This is how it looks like. And pain temperature is probably the one to be lost earliest. Therefore, if you have a metallic end and a wooden end, the tip term, which we published in 2002, is a good way of picking up this painless neuropathy. And in addition to neuropathy, neuropathy produces a condition called high plantar pressure and also limited joint mobility, which produces ulceration. So ulceration is not just because of neuropathy. In addition to neuropathy, if you have high plantar pressures and limited joint mobility, your chances of getting an ulcer, foot ulcer, is more. Therefore, what I've tried to say in the last 12 minutes is about painful neuropathy. Of course, neuropathy is very important. But what we should not forget is that neuropathy can produce a painless state with insensate feet, which combined with high plantar pressures and limited joint mobility and injury can lead to foot infection, foot ulceration, and amputation. So that's the real cause for the increased morbidity and mortality. I would like to thank you for your attention.
Okay, thank you, Dr. Vishwanathan, for those great deliberation and those excellent information on painful diabetic neuropathy as well as a painless neuropathy. Can I ask you one question?
Yes, sir. Please go ahead.
So this is, neuropathy initially is like asymptomatic. And if a patient has pain, then it is more dangerous because there may be a wound and patient comes to know. Like there's a wound and patient comes to a doctor for wound rather than for neuropathy. So what precautions and, what are the methods which, healthcare physician at the level of a primary clinic should take into consideration so that diagnosis is made at a very early stage?
So just to make the point clear, there is a stage of asymptomatic neuropathy, then the painful neuropathy, then again it goes to asymptomatic because the nerves are completely damaged, the small fibers. So it actually 3 stages are there. So what I was trying to say is you must pick it up even before the painful neuropathy starts. So every physician must test with at least a 128 Hertz tuning fork, which is there with every single doctor and medical student. And you can also test temperature, because Dan Ziegler has shown that that's the first sensation to be lost. So you can do a simple test tube of hot water and cold water if you don't have anything else in the primary care. So 128 Hertz tuning fork for the large fiber and temperature with a hot water test tube and cold water test tube to look at the small fiber. So this must be done in every person with diabetes, just like you check for retina and for microalbuminuria and so on and so forth.
So basically, pain, your prick sensations and temperature and tuning fork, which one anybody can have at 128 Hertz.
And if you can do the ankle jerk properly, it will show you the loss of large fibers very early. If you elicit a very good ankle jerk by making the person stand with his foot hanging down and you use a knee hammer, you can also pick up neuropathy.
Now, my other question is, okay, Dr. Panikkar.
Vijay, excellent. My one question is, there are a lot of combination tablets now in the market, especially a pregabalin with a nortriptyline. What is your take on that?
So as I said, sir, the first choice is, I'm just going by the European and American guidelines. There's no Indian guidelines. So first choice is either a pregabalin or gabapentin or amitriptyline or duloxetine. As I showed you the blue and the green, some 2 things I showed you. Now only if those by themselves don't work, then you should combine. But in India, generally people start with, just because the pharma companies tell them, they just start with the combination. It's not actually, it's not like glycemic control where you start with glimepiride and metformin. So here it is, you should choose one of them and usually and go up. And I was surprised that Professor Andrew Bolton says he uses pregabalin 600 milligrams. So I said, I've never used it beyond 75 or 150. He said, oh, that's a child dose, he said. So the thing is, they go up to pregabalin very high doses before they even think of combining. But in India, straight away they start 75 with amitriptyline 10 milligram or 25. So which is not a very evidence-based thing to do.
Yeah, so you rightly said, if patient has more of depressive features, amitriptyline or duloxetine.
Yeah,
and if it is more of a pain or a sleeplessness, then it's pregabalin or gabapentin.
Correct.
Now, most of the patients are on combinations. Now, these are two categories. What about the role of we have very commonly used Acuvin, Ultrasat, these kind of medications, and then local application also are very helpful sometimes. Capsaicin, salt, Capsidol ointment is available. So, what is your take on these?
So I think you can combine capsaicin with pregabalin. That's not a problem. But combining again tramadol and all that, it's shown lower in the list. So you can combine tramadol with pregabalin only if one of those four fail to give you relief of symptoms. So you can't start with tramadol because it's not the first line drug. The first line drugs are pregabalin, gabapentin, duloxetine, or
No, as a third
TCA.
line. As a third line, I was
Third
saying.
line, yes, yeah. If you don't, you can combine any two, any three. Yeah.
Yeah.
I think we are short of time. She has come again.
Sir, I again request you to please, sorry to interrupt.
Put the screen on.
Yes.
Sanjeev Shah.
Yeah. So now it's my proud privilege. Dr. Panikar, would you like to introduce him?
He's a good friend of mine.
I think that is more than sufficient. He's a renowned endocrinologist from Mumbai. He would be speaking on postprandial hypoglycemia. And I think without wasting time, we are already running short of time. So I would request Dr. Sanjeev Shah to please start his deliberation.
There are 7 studies on Caucasian population on the right. You can see fasting glucose in both the groups are identical at different A1C from 8.2 to 8.9 up to 9.8. At every level of A1C from 8.9 to 9.8, Indians have higher PPG value compared to a Caucasian. If we look at the kind of control diabetic patients have achieved, and if we achieve an HbA1c of less than 7% and a fasting glucose less than 120, many patients in that category of control still have a postprandial value higher than 160 or higher than 180. And many times we don't escalate the therapy for that selected postprandial value and we accept 7% as an acceptable control. That takes us to how therapeutically we should target a PPG value and what kind of a treatment we should achieve. If we look at all epidemiological studies, there are 62% of patients in India have higher PPG value more than 180 milligram. And there are many reasons for that. And the first one is a carb-rich diet, diabetogenic diet. Second aspect is kind of a treatment we select for those patients. We may not be oriented to selecting a drug which are specific to PPG. Indian diabetics have more beta cell dysfunction, insulinopenic, and more incretin defect, which may be responsible for higher PPG value. If we look at the recommendation of carbohydrate intake to be consumed, American Diabetic Association recommends 3, 3, 4, and 1 servings of 15 gram, 50% calories coming from a carb and remaining from fat and a protein. But Indians consume much more than that. So I could rightly say that India is the carb capital of the world,
which consumes 75% of calories coming from carbohydrate. If we look at an epidemiological study conducted by Professor V. Mohan from Chennai, they look at 470 grams of carb consumption by a man and 390 by women in a 2000 calorie diet suggests that Indian diabetics consume far more than what is being recommended. This was endorsed in another study conducted in 5 different parts of India called the STAR study, published by Dr. Shashank Joshi in British Medical Journal, where 65% of calories are coming from carb consumption. And that makes a patient to be in a postprandial phase throughout the day. A man consuming 3 or 4 carb-rich meal spends 3 to 4 hours after each meal into postprandial phase. That converts an individual diabetic into almost 12-15 hours spending in a PPG phase. Now, this PPG phase and postprandial glucose spike is responsible for multiple complications in diabetic patients. As you can see, the cellular pathway within the cell, the signaling mechanism results into triggering various cascade of complication. But in a simpler diagram, if we look at how postprandial hyperglycemia is responsible for increasing coagulation cascade, reducing fibrinolysis, and reducing the plaque stability with endothelial dysfunction. On the side of a lipid, there is postprandial hypertriglyceridemia with reduction in HDL seen in patients who have uncontrolled diabetes. In addition to an impact of PP hyperglycemia on insulin secretion, insulin resistance, and free fatty acid metabolism. If we consider PP glycemic excursion as glycemic variability, this is a meta-analysis of 22 studies which looked at patients with high glucose variability and hypoglycemia-related low glucose variability. And they compared with HOMA insulin resistance. This HOMA IR was significantly lower in patients who have low glycemic variability compared to high glycemic variability. So prandial hyperglycemia is associated with higher insulin resistance and higher the risk of atherosclerotic complications. This is a relationship between glycemic variability and microvascular complication. This is a paper published in March 2020, which looked at a small number of 78 patients with type 2 diabetes, and they related glycemic variability with ankle brachial index and neuropathy parameters. See, higher the blood glucose level, severe was the degree of lower limb ischemia and sensory neuropathy. So there is a distinct relationship between glycemic variability, mean amplitude of glycemic excursion, and microvascular complication. If we try to compare in epidemiological studies, there are many studies which have been published. HOON study, Honolulu Heart study, most popular which is quoted is a DCODE study where cardiovascular death, cardiovascular mortality, everything was related with 2 hours postprandial blood glucose. So PP hyperglycemia correlates very well with coronary events. Now, what is the right time for postprandial glucose assessment? I am posing a question for you to think whether 120 minutes is the right time or 90 minutes should be considered in some of the patients whom you are trying to control. This is the area under the curve which is plotted for 4 hours, and you can see that between 60 and 90 minutes there is glucose peak compared to 120 minutes. We all know that diabetes starts with a first phase insulin response being absent, which is responsible for postprandial hyperglycemia right at the stage of pre-diabetes or IGT, and subsequently in a period of diabetic, patient always has absent first phase insulin release, resulting into postprandial hyperglycemia. So my question is, what is the right time study that 80% of patients had a glucose peak observed exactly at 90 minutes after the start of the meal. So 120 minutes, sometime what you see is a lower peak, and we have missed out on higher peak 30 minutes before the time of what we estimate. This is comparison of 4 different breakfasts, which are exactly isocaloric, 300 kilocalorie challenge given as glucose, bread, upma, idli, and pongal. 5 different breakfasts, 4 breakfasts compared with glucose. On the left, you can see that glucose excursion is highest at 90 minutes or 60 minutes for some of the breakfast. 120-minute glucose is lower than either 60 or 90 for each kind of a breakfast. You can see in 2020, American Diabetic Association guideline also recommends estimation of postprandial glucose between 1 and 2 hours after the beginning of the meal. And so, if we have to consider a therapeutic intervention, please also consider 90-minute estimation or orientation to 90 minutes for the patients who require the best control. Let's look at the first intervention of exercise for postprandial hyperglycemia. There are 39 articles which have looked at impact of exercise being done after the meal. So post-meal estimation, post-meal exercise sometimes is also a modality to control postprandial hyperglycemia. If the recommended approach is to be seen, the rate of glucose appearance should have also the rate of glucose disappearance matching with each other, so that pre-meal blood glucose would be similar to post-meal blood glucose. This would be an ideal situation, but it does not happen in large majority of the patients, and you find that glucose appearance is much faster than disappearance of glucose. This would result into a tablet effect which is carried little beyond the peak of glucose. This would result into increased incidence or risk of hypoglycemia at 3, 4, or 5 hours after the meal is consumed. This is typically happens also with regular insulin, which doesn't cover the peak hyperglycemia, but in late period, it will cause hypoglycemia. If we have to look at a classical approach of treating prandial hyperglycemia, we should restore a first phase insulin secretion. So we should use a secretagogue in such a way that we get early insulin peak. This would improve the glucose uptake. What you see is efflux. Endogenous glucose production should be suppressed, which is not inhibited during postprandial phase. You need a metformin and you need an alpha cell function or glucagon suppression. At the same time, to prevent meal-derived glucose from high-carb diet, you also require inhibition of intestinal absorption of carbohydrate. So this is a pharmacological approach which should be implemented in the first 90 minutes of the meal to restore first phase insulin, suppress insulin resistance, and use alpha glucosidase inhibitor right at the beginning of the meal. This is a study which compares on the group 1 using metformin alone, in the group 2 metformin plus glyclazide, a combination therapy, and you can see the prandial glucose in metformin treated group reduced from 252 to 187, reduction of 60 milligram. On the right, you can see metformin with glyclazide reduced postprandial value by 100 milligram. You can see 8.9 A1C becoming 7.2, while 9.8 A1C becoming 7.2. So there's a significant reduction of postprandial hyperglycemia with glyclazide. If you have to select between glimepiride and glyclazide, you can see that there is a reduction of 136 milligram with glyclazide and only 100 milligram with glimepiride. If metformin and glyclazide is to be combined, you can see the efficacy of voglibose in real world will reduce fasting, postprandial glucose, as well as A1C. So in Indian patients, reduction in glycemic variability is extremely important, which has been demonstrated with voglibose, which increases the time spent in a range, as you can see in continuous glucose monitoring evaluation. On the left, you have glimepiride, metformin, teneligliptin. On the right, you have glyclazide, metformin, and voglibose. Patient was switched over from this combination to this combination, eliminating all postprandial hyperglycemia. There are also dietary methods which can be used to minimize postprandial glucose. which is a separate session in this conference, so I would not touch. But it is extremely important that DPP-4 inhibitors are a weak agent for postprandial compared to a potent sulfonylurea like gliclazide. Finally, in the last slide, I would summarize that drugs on the left are for basal hyperglycemia, on the right is for postprandial hyperglycemia. You can mix and match and select the best combination for treating postprandial hyperglycemia. Thank you so much, and I will take your questions.
Yeah, thank you, Dr. Sanjeev Shah, for excellent talk and giving an overview of postprandial hyperglycemia, and especially, telling us that, glucose value anything between 60 and 120 minutes can be postprandial. So that's a very good insight, and new guidelines also have changed. Dr. Sanjeev, I would like to just suggest or make a comment on this, that I think whether peaking is at 6 minutes or 120 would depend on the glycemic index of the patient, the diet patient is consuming. The carb content with higher glycemic index, maybe the peaking is occurring at 60 minutes, and if there's more of a complex, it may be occurring at 120 minutes. So I think, we can go into the details of the diet, and then accordingly, we can manage. And if peaking is occurring at, say, maybe 60 minutes, 90 minutes, we can always go for rapid acting analogs.
But that, Dr. Vinod, becomes a therapeutic intervention to modify the diet in such a way that fiber and protein content is enhanced along with carbs, so that the peak is delayed from 90 to 120 minutes.
Yes, definitely. So do we have time, Dr. Sarita? Okay.
Sir, sir, we will go ahead because Dr. Hemant Thakur sir is soon joining. By that time, we can have his presentation going on.
So we can continue. We can continue.
So I ask, no sir, we will go ahead with the next Ms. Dr. Hemant Thakur's presentation. He is joining soon. Before that, Ms. I ask the organizer to please upload this presentation. Yes.
Yeah, so Dr. Hemant Thakur is the next speaker, and I think this session is being dominated by all speakers.
Entire contraption that has been done by RX.
Yes, sorry, sir. So you were saying something, Mittal, sir?
Coming to the verdict for glimepiride and the key points to remember. So, what do the guidelines say on choosing OADs? The ESI RSSDI Joint Guidelines 2020, the recommendations on second-line therapy in type 2 diabetes. They clearly say that when glucose targets are not achieved with first-line therapy in type 2 diabetes patients, a sulfonylurea or a TZD or an SGLT2 or a DPP4 or even an AGI can be added using a patient-centric approach. Consider initiating combination therapy if the A1C is more than 1.5 above the target. Let's look at the WHO recommendations, which talk about sulfonylureas as the second-line treatment for type 2 diabetes. They say that sulfonylurea should be used as a second-line treatment, either if metformin alone is insufficient or there are contraindications to metformin. And here they say that sulfonylureas with a better safety profile are preferred in patients for whom hypoglycemia is a concern, like people at risk of falls, people who have impaired awareness, people who live alone, people who drive or operate machinery as part of their job. So they may have concerns of hypoglycemia. Look at the ADA 2020. Choosing oral anti-diabetic drugs if cost is a major issue. Now this slide I want to dwell on because not everybody attended 2020 because nobody went to Chicago. So how many of you attended the virtual 2020? So they say that patient without established ASCVD or CKD, the first line is metformin plus comprehensive lifestyle. Of course, if HbA1c is way above target, then consider early combination therapy. And they say you can choose between sulfonylureas and TZDs. After adding one of these two, if still the A1c is above target, you can again go back to the other one if you have used sulfonylurea first, look at a TZD. And still above target, insulin therapy with basal insulin with the lowest acquisition cost, or even consider a DPP-4 or SGLT2 with lowest acquisition cost. Now, the choice is to choose a lower generation sulfonylurea to lower the risk of hypoglycemia. Glimepiride has shown similar CV safety to DPP-4 inhibitors. The GLP-1 receptor agonists have disadvantages of high costs and tolerability issues. And among the available second-line treatments of type 2 diabetes, sulfonylureas are the most economical. And amongst sulfonylureas, glimepiride is the most cost-effective. So, IDF 2017 recommendations for sulfonylureas, since ADA 2020 has agreed vehemently, they say that metformin monotherapy, if it is not tolerated, then you can use even sulfonylurea monotherapy, except glibenclamide. If the initial combination therapy is to be used because of high A1C, then metformin plus SU, of course, accepting glibenclamide and glyburide. And as an add-on therapy, dual therapy, monotherapy with metformin not sufficient, add an SU, accept again glibenclamide and glyburide. But let's talk about Carolina, which is the recent evidence on glimepiride. The Carolina trial says define an ideal choice after metformin considering CV safety. Do you want a DPP-4 or a sulfonylurea? And is the largest study versus an active comparator with patient profile closer to DPP-4 to the UKPDS study. And the CV outcome trial with the gliptin with the longest follow-up. In fact, Carolina helped clarify the CV safety of long-term DPP-4 inhibitor therapy compared with SU therapy in type 2 diabetes. The question was, what is the effect of linagliptin compared with glimepiride on major cardiovascular events in patients with relatively early type 2 diabetes at elevated CV risk? About 6,000 patients in the following ratio. HbA1c levels between 6.5 and 8.5, type 2 diabetes, elevated risk, median age 64 years, 43 countries, 607 sites, 3,000 given linagliptin once daily, 3,014 given glimepiride 1 milligram daily, and up-titrated to a potential maximum of 4 milligrams daily, with up-titration occurring every 4 weeks during the first 16 weeks, plus usual care. In this study, they had a screening, a placebo run-in, when the patients were then given a comparator, which is Lina or Glimi. Lina at 5 milligrams, Glimi at 1 to 4, up-titrated every 4 weeks. And then there was a follow-up visit which continued. End of treatment, 7 days, 23 days, and this went on and on. The visit schedule after that period was 16 weeks, and then the randomization occurred at visit 2. So if you look at the inclusion study, A1C 6.5 to 8.5, if treatment naive or treated with metformin and or even alpha glucosidase inhibitor. HbA1c 6.5 to 7.5, if a sulfonylurea, glenite, monotherapy or SU-glenite plus metformin may be with alpha glucosidase for less than 5 years. And the CV risk inclusions were previous vascular disease, evidence of vascular related end organ damage, age more than 70, and more than 2 CV risk factors were present, and patients with type 2 diabetes were eligible if they met both the glycemic and the CV risk inclusion criteria. The glimepiride was up-titrated from 1 to 14 weeks, starting with a dose of 1 milligram to a maximum of 4, guided by self-monitored glucose levels. The study went on for 352 weeks, and you can see the mean dose of sulfonylurea was about 2.9 milligrams, plus or minus 1.1 milligram, versus 5 milligrams flat dose of linagliptin. The patient population involved a homogeneous as per race. Less than 5 years, 40%, 5 to 10 years, 28%, more than 10 years, 30%. They were predominantly whites, but Asian, African American, and other populations were considered. If you look at the participants who reflectively showed those that were typically seen in clinical practice. 35% had established CV disease, 37% displayed 2 defined risk factors, 41% had type 2 diabetes for 5 years. That was the median duration. They were either on metformin, on insulin, never, and treatment 9%. And they received standard of care for CV risk. The full results were presented in San Francisco 2019 ADA. And it clearly showed that amongst adults with relatively early type 2 diabetes and elevated cardiovascular risk, the use of Lina compared with Glimi over a median 6.5, almost 6.3 years, resulted in a non-inferior risk of a composite cardiovascular outcome. Showing apples to tomatoes, both of them were simply equal. And what were the key results? MACE endpoints, metabolic outcomes, and safety outcomes. If you look at the outcome summary, Carolina demonstrated non-inferiority of 3-point MACE, 4-point MACE of Lina versus Glimi in participants with relatively early type 2 and increased CV risk. And the risk for CV mortality or overall mortality was nowhere different between the two groups, as you can see in the bar diagram. And if you look at the p-values for interaction for 3-point MACE amongst the subgroup analysis, it is absolutely the same, whether with CVD, without CVD, age, with metformin and EGFR. Look at the p-values. So glimepiride and Lina are at par in terms of mortality outcomes, whether it's all-cause mortality, CV mortality, and non-CV mortality. What about the medical and the metabolic outcomes? No differences were seen in the glycemic control. Of course, A1C levels dropped rapidly with glimepiride, but by the end of the trial, both groups had returned to a baseline of 7%, as you will see the turquoise graph over the navy blue graph, with the turquoise showing a sharp dip in the beginning. And this explains the great efficacy of both of them in bringing the patients to target in early treatment period, and also explains the good durability profile, which is comparable to DPP-4 inhibitors. If you look at body weight, those in the Glimi group initially gained about 0.6 in weight, while the Lina group lost about 1 kilo. But by the end of the trial, the Glimi group weighed about 1.5 kilos more than the Lina participants. So Lina participants altered body weight by an average of -1.5. Adverse events, the frequency of AEs, serious AEs, and AEs leading to discontinuation of the study medication was comparable in both groups. No imbalance for pancreas involvement or malignancy. Of course, as expected, hypoglycemic events were lower with Lina compared with Glimi, with hypoglycemia showing less than 70 milligrams, 3 times higher, more than half in the first year when the up titration was going on. But the hospitalization for hypo was only 0.9%. So less than 70, 3 times higher, and more than half in the first year. Summary of safety outcomes. The heart failure for hospitalization leading was higher with Lina. And if you see 3.7%, and participant with hospitalization. Hypoglycemia higher with Glimi, 27 versus 2. Heart failure more with Lina, 112 versus 92. So is Glimipride in its rapid titration the reason for hypoglycemia? So since Glimi was titrated from week 1 to week 16, guided by self-monitoring glucose levels, it obviously seems to be the answer, because 1 to 4 was by self-monitoring and probably explains the reason for more hypos. Look at the heart failure summary. Participants with hospitalization for heart failure with Lina was about 3.7%, where it was 20 more in Lina as compared to sulfonylureas. Now, if you look at the Carolina, it helps resolve the decade-long uncertainty of CV safety, especially in the sulfonylurea, which has come under a cloud, and where people used to say, yes, it's good, yes, it's not. And Glimipride, the later generation, which is so potent and is so frequently well used, that cloud has now been completely cleared, because the UGDP, the findings for CV risk was higher death, but ADOPT, Advance, UKPDS, TOSCA were all neutral. And if you see Carolina, the latest long study, 6 years, no difference in the incidence of CV events with Lina versus Glimipride. If you look at the study outcome summary, the efficacy shows non-significant HbA1c levels, though they drop more rapidly with Glimi. Looking at the safety, overall AEs were comparable with no significant dropouts. More hypoglycemia with Glimi, but they did not reflect in the cardiovascular events. This is important because hypoglycemia precipitating a cardiovascular event is the problem. Weight gain, both drugs had weight loss from baseline to the end of the study. Lina had more. 3-point MACE, 4-point MACE, not significant. All-cause mortality, not significant. Even heart failure hospitalization, though numerically more with linagliptin, p-value not significant. Take-home points, very well designed, one of the longest CVOT trials conducted, more than 6 years. Despite more hypoglycemia, there was no evidence of increased CV risk with Glimipride, and the risk of hospitalization due to heart failure was numerically higher with Lina than with Glimipride. Again, not significant statistically. So clinicians now, who always had this fear that sulfonylureas, maybe in the first generations, but definitely with Glimipride, they should be reassured of the CV safety of Glimipride, because Glimipride is still the main bull that pulls the plow as far as India and developing countries are concerned. It is still a very potent hypoglycemic agent and is still widely used, and that CV safety results which have now come from Carolina should ameliorate all doubts of any nature. I think with that, I end my presentation for the simple reason that you have, though compared apples to oranges or apples to tomatoes, you have shown.
Yeah, thank you, Dr. Hemant Thakkar, for those valuable insights on glimepiride, especially on its cardiovascular safety. I think one point which you've made very clear is one is definitely cardiovascular safety. But if we are little cautious about starting low and going slow about sulfonylureas, especially these third generation glimepiride, the chances of hypoglycemia also would be taken care of to a large extent. So starting low, going slow should be the strategy in case of sulfonylureas.
Absolutely right. I agree with you. I agree with you.
Yeah, so Dr. Sarita, any questions in the chat box?
So just let me check.
So
Shlok,
if
have you
there's
checked?
nothing, everybody is fond
Yeah,
of
nothing.
Carolina and they like Carolina. And I can
Yes,
make an exit.
they are comfortable. I think
Thank
now
you.
we can
So
have.
brief session. Yeah. So
There are no questions. We can have break.
Yeah.
And right by 5:45 again we are going
Hello.
to start our next
Yeah.
session.
Okay.
Yes.
Yeah.
So I convey my
Thank you
thanks
so
to the
much.
organizers and to all the speakers, Dr. Hemant
Yes,
Thakkar, Dr. Sanjeev Shah, Dr. Tiwaskar, Dr. Vijay Vishwanathan, and all the best to everyone. Thank you. Over to the organizers.
On behalf of organizing committee, we are really very grateful to Dr. Vinod Mittal sir for nicely moderating this session. Dr. Dongawkar sir, he was also supposed to join, but some technical difficulties we found. We are thankful to him also.
Okay.
So we'll be joining by 5:45.
Thank you.
Thank you, sir.
अपन ये ना ये मी
हेलो सरिता मैम, एक्चुअली आपका आवाज अभी म्यूट है,
Oh, yes,
जिसको
yes,
अनम्यूट.
yes. Yeah, did it. So, very good evening to all of you. Within 2 minutes, we are going to start with the session. Dr. Bhartiya sir is there.
आप जैसे भी लॉगिन करेंगे ना सर.
Yeah, so other let me just check. Yes, I think still we have 1 minute left. Should we wait for 1 minute? Let others join. Dr. Vasan sir has joined.
Dr. Sanjay Deshpande sir has joined.
Yes.
So I guess we can start.
Yeah.
So
I think now we should start. Yeah. So I invite Dr. Mithun Bhartiya. He's a young, energetic, enthusiastic endocrinologist, and he has primary interest in sexual medicine. So I invite Dr. Mithun Bhartiya to moderate the session. Sir.
Hi, good evening. Good evening, everybody, and welcome you on this scenario, which is How's Your Sex Life? We have a whole agenda of a lot of talks today: testosterone, premature ejaculation, delayed ejaculation, and ejaculation, erectile dysfunction, female sexuality, as well as sexually transmitted diseases, what a clinician should know. And I think it will take through a whole whirlwind of sexual medicine. We have with us a lot of renowned speakers, Dr. Vasan, Dr. Sanjay Deshpande, Dr. Jumani, and Dr. R.P. Singh from Nagpur. And I think without much waiting, I request the hall in charge to kindly start the proceedings with the first talk on testosterone and diabetes.
Yes.
Good evening, everybody, and I welcome you on to this nice symposium that has been arranged. And as the opening batsman, I've been given a talk about diabetes and testosterone. So, and I think there are 2 points that needs to be kept into account, keeping in mind the topic and reality. 2 things are the most important things in life. One is sugar and the other is sex. And I think testosterone is something that bridges the gap between both the sugar and the sex modules of our life. So I have very few slides, but what I'm trying to do, rather than talk about many slides and so videos, I shall try to touch upon the practical tips that we need as a busy clinician, so that some take-home messages are very clear when we are going to practice in our daily life. So let us, as practicing clinicians, we always discuss with cases, and that puts the whole matter into perspective. So put up a case in front of you. A 30-year-old man with diabetes who is on insulin and tablets of 6 to 7 years duration has been admitted with sepsis. Now he has background retinopathy, HbA1c is quite decent at 6.9. Now what happens in life, a lot of things when you are actually in a bed, you reflect back and a lot of things come into light for which you want to then to speak about. Similarly, जब हम क्लिनिक में बैठते हैं और बाहर वेटिंग रूम में पेशेंट जितना ज्यादा वेट करता है उतना उसके प्रॉब्लम्स डॉक्टर को बताने के लिए उसका लिस्ट बड़ा होते जाता है कि उसको याद आ जाता है 6 वीक्स पहले मेरे को कान में भी दर्द हुआ था, 2 सप्ताह पहले पाँव में भी दर्द हुआ था. So when people have more time, that unimportant things, or i.e. not the unimportant things, but other things which he has been ignoring for so long also come to the forefront, and he mentions that. So he mentions to his intern, you have a young intern who is doing the round, and he complains to them, Because, I have erectile dysfunction. My wife has been complaining for a lot of time, and I have been thinking that I've been very busy. Life has been very busy. But now reflecting back, it has been there for some time. So kindly do something about it. So the astute intern, who is just fresh, bursting with energy, reads about it and checks his testosterone, which he finds to be low. Now, this young man has not been married and has no children. So the question now here is, what will you do with this low testosterone result that is in front of you? So let me put the 4 options. One is we prescribe some testosterone gel that you can prescribe, which is widely available in the market. We prescribe Sustanon, the age-old, very nicely available across everywhere, 4 weekly injections. Sometimes people give it 6 weekly. Or we give a 3-monthly slow-release depot injection of testosterone, or we do nothing. So I shall brief for a moment so that you can gather your thoughts and think about what option you would like to do. We are not put a voting pad, but I'm sure you can reflect back and think in your mind what is that you would do at this point of time. So I'm just going to hold up for 5 seconds. So by now, I think you've made your choice. So let me just go through the various options and discuss which options are right and which options are wrong. Now, very early on in my medical training in England, I was taught one simple rule of law, that no option is a wrong option. We are looking at which option is the best option in life, because medicine, as we all know, is not black and white. There is a lot of gray component to it. So we can, if we are going to give him testosterone supplementation, we can go down all the 3 avenues that are there. But the question is, should we hold our guns and wait? Because what has been taught to us in medical school with our Hippocratic oath is do no harm to the patient. And what has been taught very nicely when I was doing my training in England in endocrinology is no option is always a good option. So none is the right answer. And let me tell you why this is the right answer in this option. So when a patient is unwell, the testosterone will come back low. Whatever you measure, free testosterone, total testosterone, whatever you believe in, we shall come to that in a later part of the meeting. But both of them will come back normal, say low. So it will be low, artificially low, which is a reflection of a sepsis. So anybody who is unwell, you should never ever check the testosterone. Like when somebody is unwell, the ferritin goes high. We do not say, "Arey, iska ferritin bahut high chala gaya," ya CRP high chala gaya. This is how the body responds to it. When a person is unwell, we do not check the cholesterol because we know that will be artificially altered as well. So similarly, when a person is unwell or septic or admitted in the hospital, please do not at any circumstance check the testosterone. That is the point number 1. The point number 2 out here is, if you check the testosterone, what are you going to do with the results? Suppose you check the testosterone when he is not unwell. Now, what will you do with the results? So a simple rule of law when it comes to testosterone. You see, we all can make mistakes in life. I have made many mistakes. I'm sure every physician, it's a learning path. We have always learned from mistakes, and we teach the next generation not to do the same mistakes. Similarly, our lab is not lab proof. So if the lab has accidentally make any error and you have labeled somebody as low testosterone, you are subjecting this gentleman to a testosterone supplementation for life, which has its own problems. So always, if a low testosterone, you should recheck the testosterone to make sure that it is low, or there are no other factors, temporary factors which has caused the artificial. Check it in the early morning, preferably before 11 a.m. You don't need to fast to check the testosterone. So that is the 2 points that we have discussed so far. Number 1, do not check testosterone when you are unwell. Number 2, if you're going to check a testosterone if it's low, please repeat it before you actually start prescribing medication. Number 3 is, what are you going to check? Are you going to check total testosterone, or are you going to check free testosterone? So as a rough rule, I say free testosterone is better than total testosterone, but free testosterone is only better to be done by equilibrium dialysis. Most of the labs in our city would not be doing equilibrium dialysis. So from that viewpoint, please do not test free testosterone. If you are going to test, you test total testosterone plus sex hormone binding globulin, and there are certain formulas. You just put the total testosterone, the SHBG, the age, and you shall get the bioavailable testosterone, and you'll get the range. So that is still a better version of what you should do if you want to check the testosterone. Now, next question is, should we check the testosterone? So my point is, I think testosterone should be checked, provided you are ready, you have mentally decided that if the testosterone is low, you're going to replace it. For example, in our clinic, we check thyroid. If the thyroid is low, what we do? We prescribe thyroxine. Do we say thyroxine is for 2 months, 3 months, 6 months? 2 injection ले लो, 3 महीना ले लो, वापस देखेंगे? नहीं. अचानक से the thyroid does not start producing thyroxine. Similarly, if the testosterone is low, whatever reason it could be, hypo or hyper causing the low testosterone, the testis has not been able to produce testosterone. So it is not going to one fine day start that chalo aap testosterone, COVID khatam ho gaya, abhi testosterone banate hain. Aisa nahi hoga. So you are committing yourself to replacing this testosterone, and you should also tell the patient, I'm checking your testosterone. If it's low, it's a supplementation for life. So that mental frame of mind, should you be ready and the patient be ready? Otherwise, do not subject the patient to a test, which I think in most places with SHBG, it costs around 3,000 to 4,000 rupees. Now, let us look into a better scenario now. You have checked, everything is fine, he is not unwell, your lab is perfect, you have done equilibrium dialysis, you have checked free testosterone, it is low, you've repeated it, that is also low, he is married and he has no children, which is the real question that we had. What are you going to give this person? Are you going to give him testosterone gel, Sustanol, or 3-monthly injection? Because none does not actually stay here, option in this question. Now you see the important factor out here is that he is married and has no children. So testosterone supplementation can cause problems with your sperm. So you may be able to affect his fertility of this poor guy. So it is important that you either counsel him. There are other endocrine ways of improving testosterone, which is beyond the scope of this lecture, and refer to him to somebody who has an interest in a young man who's married, wanting children and has low testosterone. But you do not actually prescribe this guy any testosterone. Otherwise, he will not have any child. There is a possibility, and he will sue you in future life. That option. Now, let us again change the scenario in the same question. Let him make him married, and he has 2 children now. They're young children under 12 years old. What will you do if he has a young child who is under 12 years? Please do not prescribe him testosterone gel, because young people we hug our children. So you may apply the gel may not get absorbed from your skin. And if you hug a child, if you have a female child, the patient has a female child, will be suddenly growing hair, which will not be acceptable, and it will do a lot of harm to our patients. So that factor needs to be in consideration when you are going to prescribe. Now let us take a scenario again. Same question, same scenario. Married, children are grown and big. He is around 50-year-old. Now what are you going to give? In that scenario, you can give the gel, you can give Sustanon, you can give 3-monthly injection. I am not a real fan of Sustanon injection. One of the reasons for that is you get a peak and a trough. Suddenly, 2 weeks later, he will feel he is on the top of the world, like a bipolar disorder. He's a manic, and then after 3-4 weeks, when the testosterone is oozing out of his body, he will suddenly feel very low in himself. So you are going to give him a lot of mood fluctuations, which may have a lot of impact on his productivity, of his social productivity life and his financial productivity life, and he might hate you for it. So you may, one of your people who generally, there's a joke, I don't take this seriously, but they're generally reserved for patients who give you a lot of agony. But I don't mean that you prescribe for any patient Sustanon injections. So testosterone gel and a 3-monthly injection, both of them are good options at this scenario. So my friends, on this slide, we have talked about a few options. The take-home messages so far is, do not check testosterone in sepsis. If you check testosterone, if it is low, please repeat it. check it between 9 a.m. to 11 a.m. Between total and free testosterone, unless you have equilibrium dialysis, please check total testosterone SHBG. If you're going to check low testosterone, please counsel the patient. It's a treatment for life. If you are going, if a person does not have a child or is planning a children, please refrain from prescribing testosterone supplementation. If he is married and has grown up children, we have various options, and one can authorize any of the options, and they may differ in some advantages and disadvantages that may be there on this scenario. Let's move on to the next question. What is the hoo-ha about diabetes and testosterone? The FDA had given a statement saying that testosterone supplementation may cause problems with the heart. And that was based on 3 studies. And there was a massive negative work done on all the hard work that was done on testosterone. I shall not go in the very big details for the purpose of this meeting. But what I want to point you out, there were a lot of drawbacks of the study which actually made the FDA. For example, one of the studies came back and said actually they had mislabeled men and women in their studies, and they retracted the paper. So, there were a lot of controversy. All the studies were not foolproof. They were not adequately powered to look at cardiovascular outcome studies. So you need to have adequate, why after rosiglitazone fiasco, which I would say not a fiasco, but a wrong decision, we do now cardiovascular outcome trials. There's a reason, because the study has to be powered, the endpoints have to be defined right at the study for us to get any meaningful results out of the various studies. So I shall come to a study like that which has been designed in the future. But before that, I would always urge you to actually read a paper in Diabetes Care, an excellent paper which is an 8-year registry by Dr. Yasin et al., which suggests that testosterone therapy in men with hypogonadism prevents the progression from pre-diabetes to type 2 diabetes. Again, as I said, this is not a cardiovascular outcome trial designed to look at it. So what is there in the pipeline that we see that is going to be there? Now, there are 2 wonderful trials which are in the pipeline. Number one is the TRAVERS trial. Now, the TRAVERS trial is the first RCT that is adequately powered to look for cardiovascular events with testosterone replacement. It was started in 2018 and it is for 5 years. By 2023, we will exactly know whether cardiovascular risk is increased, decreased, or it is, as we say, the new fashion term, it is CV neutral when you give testosterone to our diabetic patients. The next one is more specific for our diabetes, which is the T4DM trial, which is in Australia, in which they took testosterone replacement therapy with lifestyle in hypogonadal pen, and they saw whether these people progress to diabetes or not. The results are expected in 2020 at any time. I know in the grapevine the results are really good. I cannot, because the author has actually not published. I have hands to the results, but I cannot take the thunder away from all his hard work. But the results are something to watch out for, and I'm sure a lot of things are going to change once this trial report comes out in the next few months in the pipeline. Now, so where are we standing so far when it comes to testosterone and when it comes to diabetes? So my suggestion or my advice to people would be, all of you are expert physicians, all of you know what you're doing. Testosterone presently is a wavy water. Please surf on this wavy water only if you are confident you can surf everything and answer everything. If you're not confident, because the landscape is changing very frequently, I think with the T4DM trial coming out, we will get a much better clarity. And with the TRAVERS trial, we'll get a superb clarity on cardiovascular outcome data. Till then, I would suggest, if you are actually wanting to look into testosterone replacement, because just testosterone replacement is not just easy just to prescribe testosterone. The person has to be screened so that the hematocrit value does not go as we have to screen for CBC, we have to screen for PSA annually, though there is no presently correlation with prostate cancer. The whole idea is that it may unmask the screening with a prostate cancer rather than causes prostate cancer. But I would urge that if you are actually going down that route, I would urge you to actually refer the patient to somebody who has an active interest in testosterone replacement so that the patient gets the best advice and help. And you have done the patient much more a favor, unless you keep into tune with the changing trend of testosterone publications that are coming very frequently. With that, I end my presentation, and I would be very happy to take any question answers. Thank you so much.
I think we've discussed the testosterone, and I think we shall take all the question and answers at the end of the meeting. I next invite Dr. Vasan sir to kindly do the next talk. Dr. Vasan sir leads the Society of South Asian Sexual Medicine. He's one of the pioneers of sexual medicine in India and as well as in Southeast Asia. He's worldwide known. He's a urologist by training and who started andrology training in India. He is part of the Manipal Institute of Andrology Training, which he had started in fellowship programs. And he's the best person who is going to tell us about ejaculation, practical tips as to how we deal with premature, delayed, and anejaculation. Over to you, sir. And good evening, sir. Dr. Vasan, sir?
What are the current management principles? We all know that this is a distressing problem which probably affects almost 20 to 30% of the population, which causes important psychological problems in the form of diminished self-esteem, anxiety, embarrassment, and relationship problems. There are various PE subtypes, but the classical ones are the lifelong, which is the primary premature ejaculation, and the other one is the acquired, which is the secondary premature ejaculation. So the primary is supposed to have a genetic polymorphism of the 5-TT-LPR gene, which determines the regulation of intravaginal ejaculatory latency time, or IELT. The acquired variety is the other one, which is less distressing, wherein sufferers develop early ejaculation at some point in their life, having had previous normal ejaculation. This is quite a heterogeneous population, which is most often associated with performance anxiety and erectile dysfunction and various other etiologies. The classical algorithm for evaluating premature ejaculation is, of course, the patient partner history, assessment of whether this is a pure premature ejaculation or it is associated with erectile dysfunction, and whether it is lifelong or secondary premature ejaculation. Because the treatment modality changes if you have PE secondary to erectile dysfunction or other sexual dysfunction. Because primarily, if PE is secondary to erectile dysfunction, you manage the erectile dysfunction and not the PE. Whereas if the PE is primary, then you classify it as acquired or lifelong, and then you follow it up with suitable therapy. So that is what is the classical algorithm. Generally, we try to withdraw the drug therapy after 6 to 8 weeks to see whether we can stabilize the patient or we need to continue the treatment for premature ejaculation even further. So treating of premature ejaculation essentially consists of addressing the problem which occurs at either the cerebral level or at the spinal level or at the bulbocavernosus level or at the glandular level. That means which area is likely to induce the premature ejaculation, as this slide shows you that there are, at the cerebral level, you have the serotonin inhibition, at the spinal level, you have the inhibition of the ejaculatory generator, and mechanical contraction at the bulbocavernosus level, which can be inhibited by botulinum or topical anesthetics at the peripheral level of the glans penis sensation. So the various pharmacotherapy which have been tried are the daily intake ones or the demand intake ones. The daily intake ones are your paroxetine, sertraline, citalopram, fluoxetine, escitalopram, at various dosages which are well recognized and which are available for physician to review. On demand, the only drug which is FDA approved is dapagliflozin, and of course we use clomipramine in a dose of 10 to 40 milligram, and of course local anesthetics. These are primarily the mechanisms of ejaculatory delay which we can achieve by drugs. In various studies, the SSRIs at the lower dosage, which is your paroxetine, fluoxetine, sertraline, fluoxamine, have been tried, and they are known to delay ejaculatory latency time. And among all this, paroxetine and fluoxetine are the most preferred ones. As you can see in this graph, that paroxetine delays ejaculatory latency the maximum, and then you have the fluoxetine, and then you have the other fluoxamine and sertraline and so on. But bear in mind, many of these drugs cause erectile dysfunction, so you need to have a good erection before starting this medication. Dapagliflozin is the first compound specifically developed for the treatment of PE, and there's a level 1A evidence to support the efficacy and safety of on-demand dosing of dapagliflozin. And as you can see, dapagliflozin at 30 and 60 milligram has good effect after the first week, which is persistent and which reaches maximum efficacy by week 12 of the usage. And these are essentially on-demand medication. Now, we have, through the South Asian Society for Sexual Medicine, have decided a basic algorithm which is developed like this, where we have premature ejaculation, and if it is associated with coitus or on masturbation. So if you have premature ejaculation associated with coitus, then you rule out sildenafil, you rule out erectile dysfunction. If there is erectile dysfunction, you follow the ED guidelines. That means you start on sildenafil. And if there is still persistent premature ejaculation, then you give dapagliflozin. However, if there is no associated erectile dysfunction, you initiate dapagliflozin 30 milligram on demand, and usually you give a pack of 4 tablets, wherein you tell the patient that you take 30 milligram, again 30 milligram. If he is unsatisfied, then he increases it to 60 milligram. If there is relief, then he continues 60 milligram dapagliflozin. If at the end of 60 milligram there is still no relief, then you decide to refer him to a specialist. Similarly, if the patient has associated erectile dysfunction, then you start him on initially sildenafil, wait for a pack of 4 tablets. If there is still persistent premature ejaculation, then you add dapagliflozin, and if there is relief, you continue as a demand therapy. If there is no relief, then you refer to a specialist. This is a simple algorithm which can be instituted by any diabetologist or a physician in his day-to-day practice. Of course, there are patients who have intractable or lifelong PE or not amenable to medical therapy or have significant side effects to medical therapy. Then you have various forms of surgical therapy. One is the cryoneurolysis of the dorsal penile nerve. All these are experimental therapies. They have not stood the test of time, and efficacy rates at best with any of the surgical therapies, which I'm going to discuss, is at best 50 to 60%. And this is the equipment used for premature ejaculation called cryosurge, which is used for cryoneurolysis. Then you have the selective penile dorsal neurotomy, wherein you identify the deep dorsal nerve and you selectively ligate the deep dorsal nerve, causes penile hyposensitization. Then you have the pulsed radio frequency or the neuromodulation of the dorsal penile nerve using an RF cannula. And again, the concept is the dorsal nerve of the penis at the Levnocock position is identified, and pulse radio frequency is given to this nerve in order to desensitize the nerve. And then you have, like I said, if you have bulbocavernosus, excessive activity or hypersensitivity, which is causing the premature ejaculation, Then you have the botulinum toxin injection directly into the bulbocavernosus nerve. And this is a new study which is on a botulinum toxin, which is given in either a 30 milligram dosage or a 60 milligram dosage, and found to be effective in limited studies in men. And this is yet to stand a larger scrutiny. Now, then we also have inhibition of the rhythmic bulbospongiosus muscle contraction for intermittent electrical stimuli, and application of intermittent electrical stimulation triggers muscle contractions, which is a commonly recognized treatment to improve muscle function. And this is where you have devices like transcutaneous posterior tibial nerve stimulation, or the neuromodulation device which is coming into the market called Morari. So transcutaneous posterior tibial nerve stimulation, or TPTNS, is evolving therapy which is supposed to reduce premature ejaculation in chronic lifelong premature ejaculation. And Morari is an external device-based PE treatment using neuromodulation, which is again a therapy which is evolving in the treatment of neuromodulation and premature ejaculation. So to summarize, premature ejaculation is a distressing problem. You have to classify it as primary lifelong or secondary, which is acquired, and then tailor your treatment depending on the patient needs, either pharmacological, and distressed patients have always the option of going for further advanced modalities of treatment. This is an evolving field, and hopefully we'll hear more about these new therapies in due course of time. My second part of the lecture was delayed ejaculation. I'll briefly summarize delayed ejaculation for want of time. This is a clinical conundrum, which is premature ejaculation, delayed ejaculation, or anejaculation. And this is a much less diagnosed or underdiagnosed or untreated problem, which is delayed ejaculation, because it is much less frequent and rare reason for medical help. First of all, is it a disease? Girls should be happy because there's no ejaculation happening. Where is the problem? Unfortunately, though we think girls or women are happy, they are unhappy with delayed ejaculation. So the recommendation is DE or delayed ejaculation should be evaluated with a full medical and a sexual history and a focused physical examination and any investigation suggested by these findings. The aging phenomena which happens in all men, the seminal volume, testosterone levels, prostate contractility, vesical contractility, vas deferens contractility, these are the ones which are supposed to be a phenomena which gradually deteriorates over aging, or is the causative mechanism for delayed ejaculation. So the treatment should be etiology specific and may include patient-couple psychoeducation, psychosexual therapy, pharmacotherapy, or integrated treatment. Men partners of reproductive age may require preoperative sperm cryostorage, sperm harvesting, and assisted reproductive technique. Patients with psychogenic inhibited ejaculation are challenging to treat population, and they require psychoeducation and psychosexual therapy. And the various drugs which are used, basically they are off-label, are ephedrine, pseudoephedrine, desipramine, yohimbine, cyproheptadine. So all these are off-label drugs used in various combinations, but they are approaches which can be tried. Recommendation is there is a level 4 evidence to support the treatment of delayed ejaculation pharmacotherapy, and this is left to the individual choice. To conclude, delayed ejaculation, anorgasmia, and anejaculation are very difficult problems, and there could be various groups of people where they have never ejaculated, sometimes ejaculated, or always ejaculate with masturbation, and so on and so forth. And so this algorithm describes how do you manage them. Thank you very much for your patient listening, and wishing you all the best for this conference. Thank you.
Thank you, Vasant sir, as eloquent as you are always. We move on. We shall take all the question and answers at the last. Now I invite Dr. Sanjay Deshpande sir. Dr. Deshpande sir needs no introduction to people of Nagpur. He belongs there. He leads the CSE PI. He leads a lot of education for diabetes. He's a champion for sexual medicine, and he's going to deal with a case-based scenario discussion on female sexuality, a topic which we generally do not talk about, and he's going to tell us how we approach that in a clinical scenarios. Over to you, sir.
To think about, so dear friends, at the outset, I must thank Dr. Sunil Gupta for giving me the opportunity to share my thoughts on this female sexuality. In fact, whenever we say that it is very difficult for a man or for the entire society to think about women, just like one Sanskrit verse says that Nrupasya Chittam Kurpanasya Vityam Manoratha Durjana Manavanam Priya Charitra Purushasya Bhagyam Devo Na Janati Kuto Manushya. इसका मतलब है, the meaning of it is that we can't know what a king feels, what a miser has the property, what a bad person has in his mind, what a fortune of a man, and same thing is that even the God also does not know what the woman feels. That is very important. In order to just prove our points and just share the female sexuality, I will be approaching this female sexuality issue case by case. This was one case, a 34 years man complaining of erectile dysfunction came to our clinic. He was non-diabetic, normotensive, testosterone level were normal, but the sexual history suggested that wife complains of vaginal infection and repeatedly with lot of bleeding.
You know this.
Asked to come with his wife, but he was reluctant. He did not wanted his wife to come with him. So we checked, referred her to an OBGYN expert where she was advised. Then during the treatment with gynecologist, she was found to be diabetic. Now we have to understand that diabetes is a very potent enemy of sex life of not only of a man but of a woman also. How it affects is that hyperglycemia reduces the hydration of genital mucosa. Then it poor vaginal lubrication, dyspareunia, and it can lead to infections. So sexual discomfort can start, itching can start, burning and irritation also can start. Sometimes there is pain, general discomfort in pelvic region, and then woman is not desirous of sex. So in fact, in this case, what we saw that a simple diagnosis of diabetes mellitus is was very important in this case. Then comes case number 2, that a 45 years old female was complaining of lack of sexual desire. Then sexual history revealed that there was a vaginal dryness, and hence she used to avoid the sexual intercourse due to fear of pain and injury. When she was referred to a gynecologist for any OBGYN pathology, there was absolutely normal. So routine investigation again diagnosed her as a diabetic. After regular treatment for diabetes and prescription of some lubricants, she started her sexual life happily again. So sometimes it is very important and very simple to treat this woman. If we see this physiological mechanism causing sexual dysfunctions in women with diabetes mellitus, there are many causes. The most important cause is hormonal cause. Low estrogen levels can affect lubrication of vagina because this woman was 45 years of age in the perimenopausal age group. There may be lethargy, loss of interest, fatigue, and depression also. Psychologically also there may be sometimes anxiety, stress, low self-esteem, body image perception disorders, that my body is not good, I am gaining a lot of weight, my breasts are not normal, and everything. Then sexual performance anxiety also plays a very important role. It's not only in man, but women also does suffer from sexual anxiety. Then depression is also very important. We have seen that diabetes and depression have bidirectional relationship. That's why they are and arousal. There may be some socio-cultural issues also where there is very limited social relationship, financial difficulties, religious beliefs, and lack of exercise. Many times, even if somebody feels about some sexual issues, the women, they don't consult neither their physicians nor gynecologists and forget about consulting sexologists. Then we can go to case number 3. In case number 3, what we see is that a 35 years old married woman came to us. She was complaining of pain during sexual intercourse. She had a depressive mood, which was later confirmed by a psychiatrist that she is suffering from depression also. So then she was referred to OBGYN specialist for examination, and during her checkup, she was again found diabetic. Her symptoms subsided after treatment of diabetes mellitus and depression with sex therapy. So many a times the continuous treatment with a diabetologist, with a psychiatrist and a sex therapist is important. So simultaneous treatment is always advocated so that all the concerns can be taken care of. Now when you see that sexual dysfunction in women with diabetes mellitus, we always say that diabetes glycemic control is not correlated with the frequency of the dysfunction in these patients. So some patient may be glycemically very controlled, but still they may have sexual dysfunctions. Sexual dysfunction is especially highly prevalent among those with comorbidity of depression. So depression also has to be evaluated properly. Then case number 4, a 45 years diabetic woman having orgasmic dysfunction. Means she was not able to achieve orgasm. In sexual history, what she was revealed was orgasmic dysfunction was due to the premature ejaculation in her husband, who used to ejaculate immediately after insertion. Also less frequency of sexual intercourse due to a reduced desire secondary to orgasmic dysfunction. Here we have to understand that there is a normal human psychology that whatever pleases you, you tend to do it more and more. So if the woman is unorgasmic, is not able to achieve orgasm, she will not be having desire also. So one has to establish whether actually it is orgasmic dysfunction or a desire disorder. Now what happens during diabetes? Because of vascular complications, because of endothelial dysfunction, as we see in erectile dysfunction in men, it can affect blood supply to vagina also, thereby not having proper sensations and proper venous engorgement. Even diabetes can cause neuropathy and neurological disorders also. So there may be some structural and functional changes in female genitals. There may be reduced sensitivity, and that can impair the sexual response, and she may not get the orgasmic response properly as she used to get previously. Then this is the last and fifth case. A 39 years of old diabetic woman came to us with the complaint of lack of sexual arousal. Now in the detailed history, what we found was very common in our Indian setup, that her husband was a tobacco chewer, and due to his bad breath, she did not feel any desire to have sex with him. So it's not always an organic cause. It's not always a psychological cause. But sometimes there are many other problems in the couple's dynamic. A history of smoking, alcoholism, tobacco chewing, that also may repel a woman because of the bad odor and breath. So there are a number of psychological causes also. If there is an organic cause, the psychological causes also plays very important role in female sexuality. The first which we saw is anxiety. Whether I will be able to achieve orgasm, whether I will be able to satisfy my partner, whether I will be able to get the sexual intercourse properly, whether I will get pain or not. These are many anxieties a woman has. There is a performance pressure also because of these anxieties, that I should be very good in sexual being with my partner. Because of diabetes, because of many other comorbid conditions with diabetes, there may be tiredness or sense of fatigue. There may be anger, not only towards the partner alone, but maybe because the woman feels helpless. Sometimes this helplessness also can bring out the anger about herself only. There may be mood swings if she is in perimenopausal age. There may be comorbid depression with the diabetes. So these all things has to be taken care, and one has to also establish there is no any interpersonal problem like addiction of any partner, poor hygiene, because many times the hygiene of the genitals is not proper, and that may also reduce lot of pain in woman herself or lot of problems because of the improper hygiene in the husband. Now the very important aspect which many times we may forget, that thyroid disorders are also very common in diabetics, and that is more in females. And sexual dysfunction associated with diabetes and thyroid disorders both. So it can be either because of thyroid disorder, it can be either because of diabetes, or it can be because of both the comorbid conditions. So evaluation of thyroid status is also very important. Now risk of sexual dysfunction is very high in women with diabetes. It is independent predictor of female sexual dysfunction for age, metabolic syndrome and atherogenic dyslipidemia. Depression and marital status are the main independent risk factors for erectile dysfunction, and high level of physical activity was protective for female sexual dysfunctions. Many a times it happens because of gender issues in treatment setups also. Women, they don't discuss much about their physical activities, their weight and everything with a male physician or diabetologist. So one has to definitely take into consideration whenever we are treating a woman, we must also tell her about the weight reduction, physical activity for having more sexual pleasure. Now we have to see what are the most common sexual dysfunctions in men and women. In men it is erectile dysfunction, premature ejaculation and lack of sexual desire. But we are not going to discuss this here because our main focus is female sexuality. Sexual problems in females, dyspareunia, pain during sexual intercourse. Now if there is a pain during sexual intercourse because of any reason, the desire of a woman will be very less. Many times the pain is so severe and the psychological reaction to this pain is even more severe. That can create a vaginismus sort of problem in a woman, that just a thought of penetration inside the vagina can start the involuntary vaginal contraction or spasm in that woman. So there may not be entry of penis inside the vagina possible. So vaginismus also can be a sequelae to dyspareunia, constant dyspareunia. Then orgasmic dysfunction. She may not be able to achieve the pleasure or orgasm out of sexual contact, and lack of sexual desire. So sexual desire may not be just because of the hormonal imbalance. It may be most of the time psychological or because of the pain or fear of pain. The most common causes of sexual dysfunctions are diabetes, hypertension, metabolic syndrome, coronary artery disease and obesity. And this is for both the genders, in males as well as in females. But what happens, we oftenly discuss, or we most of the time discuss only erectile dysfunction as a sexual dysfunction. But we don't discuss other sexual dysfunctions in males as well as in women also. So women dysfunction or sexual dysfunctions are the least discussed sexual dysfunctions. Now, when we had a study at our clinic, what we found that only 1% of our patients were females. So women discuss their problem least with male sexologists. So they don't discuss with male physicians too. And doctors also seldom ask about the sexual life of diabetics. So one has to definitely start doing this whenever we get a patient of diabetes, be a man or a woman. Prevalence is very wide range from 20 to 80% and should be considered especially in patients with nephropathy or retinopathy. When there are complications more, the chances of female sexual dysfunctions are also more. As you see the research findings, there are various sexual problems because of diabetes, problems in lubrication, desire disorder, problem with arousal, dyspareunia, orgasmic dysfunctions, and problems in overall sexual satisfaction. So nearly more than 40% is the rough prevalence, but when you take out total prevalence, it was just around 78%. So very high percentage of sexual dysfunctions. Now, how can diabetes affect a woman's sexual life? Either through sexual desire or inadequate vaginal lubrication, inability to achieve orgasm because of vaginismus, because of pain during intercourse, or non-coital sexual pain disorders. FSD is always correlated with lower education, lower income, urinary tract symptoms, cancer survivors, history of sexual abuse, trauma to genitalia, use of antidepressants, and disturbed spousal support. So spousal support also has to be established, and this can be very well done when a couple is counseled than an individual. But there are many challenges also. We have very less trained female healthcare or medical professional in sexuality issue. In a crowded setup of a physician or diabetologist, there is a lack of privacy and confidentiality. Social taboo attached to the subject of sexual health. Health and gender inequality, because men discuss more about their sex, women they don't. And lack of resources or medical services. So this often leads to a woman not to disclose her sexual issues with the treating physician. There are many personal taboos also regarding sex of a woman, of her partner, and of her physician also. Confidentiality issues we have already seen. Worries about potential humiliation. That if I discuss this, somebody may humiliate me or laugh at me. So I don't want to discuss. Is the usually women's psychology. Time constraints. A doctor is very much occupied with a lot of patients. So one has to hurry about telling our own complaints about diabetes and other things. So time constraints also are there. And many times doctors limited experience in the management of sexual problem. I don't say it's limited experience, but sometimes it is an attitudinal issue. The doctor is himself or herself hesitated in asking these questions, and that's why he may not ask the questions to the patients also. So what a physician can do to help this patient, that always has to understand that sexual performance is an aspect often neglected in daily practice. One should be aware of the possible presence of sexual dysfunction in female patients too. Sexual history has to be a routine part of evaluation in females with type 2 diabetes, and identify pertinent pathology or refer them to the appropriate management. Now, there are a lot of treatment options for sexual problems in women with diabetes. For lack of lubrication, a simple lubricants and education, or if needed, hormone replacement therapy can be given. Genital infection, treatment of genital infections, and teaching them genital hygiene. Dyspareunia, investigation and treatment of underlying condition. Lubricants, and reduce focus on penetrative sex. That the couple has to be educated that it's not always insertion of penis inside vagina is most important, but the sexual pleasure is very important rather than the sexual intercourse as such. Then anorgasmia, penetrative or non-penetrative vibrating sexual aids, clitoral therapy devices, psychosexual support or sex therapy. For reduced libido or desire, review any and treatment any concurrent depressive illness, psychosexual support, even some hormonal supplementation also can be tried. Estrogen or androgen replacement can be considered. Phenylephrine also can be tried, but it is of not much use. PDE5 inhibitor was also tried, but they are not very useful in desire disorders in women. There can be lifestyle interventions also, a healthy diet, routine exercises. It's not problem in India most of the time smoking, but nowadays it has started. So one should not be hesitant in asking the history of smoking also, and appropriate therapies for optimum glycemic and metabolic control, including hypertension and dyslipidemia. So the practical pulse which I just want to give here for all of our friends is that early screening of diagnosis for diabetes mellitus in female sexual dysfunction, because there may be both way it is important. In a non-diabetologic setup, when a woman goes and asks that she is suffering from female sexual dysfunction, then she should be screened for diabetes. Or if a woman is coming to a diabetology clinic with diabetes, a diabetologist must ask that whether she is having any sexual issue. Repeated vulvovaginitis for obstetrician gynecologists, for general practitioners, if there is a repeated vulvovaginitis, then one must suspect always about diabetes first. Sex education and counseling is as important as drugs, because we have seen in these cases that many a times a simple education, many a times simple positions in young married couples, that also can solve the problems. Many a times a simple habit like tobacco chewing or having a good bath, keeping proper hygiene of a partner also can increase the sexual desire, the orgasms, and the sexual pleasure in the woman and the couple as a whole. Vaginal lubricants and moisturizers for vaginal dryness and dyspareunia in postmenopausal women with diabetes and without diabetes also. That helps them to enjoy sex without any sufferings or pain. So simple lubrication can be better, because it is always said with a woman. Many times our patients ask that when can a woman, till what age a woman can achieve or experience pleasure in sex. Our answer is till that age, till her partner is able to have sexual pleasure in her, able to have erection in her. So a loving and interested partner for treatment of sexual dysfunction in a female is most important as a sex therapist or a diabetologist. So I think that is all about our case-based approach of female sexuality in diabetes. So I again thank all of you for the patient listening about this topic of female sexuality. I again thank Dr. Sunil Gupta for giving me this opportunity to share my views and experience with all of you, so that there is a constant interaction between all of us and we know.
Thank you. I think the voice got muted. Thank you so much, Dr. Deshpande sir. And I think the challenge is talking about female sexuality, because very often that is something which is not generally discussed. And Deshpande sir has very seamlessly brought about cases, give us some practical tips as to how to approach in a case-based manner to common things that come to our clinics. I think from here, let's move on from the female to the male. We shall do all the question and answers at the end. From here, let's move on to male, and I invite Dr. Deepak Jumani. Dr. Jumani needs no introduction. I think he will always entertain us and educate us with his lecture. Over to you, Jumani, sir.
To tell you some, give you some nuggets of wisdom on how do we manage medically the most important sexual dysfunction in males, which is the erectile dysfunctions. With pranams to God, and I thank my teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Shashank Joshi, and I beseech them to bless me always. Prime Minister Modi was very sad when he announced lockdown, but in fact, this lockdown was the boon to us. It was because of lockdown that we are able to see each other and talk to each other today. Things would have been very worse. Look at his hands are down. But at this lockdown, one thing which I found was a boon was if we look down, how beneficial it is, that we should realize it. If you look down within yourself, it's a boon to yourself. If you do not want erectile dysfunction, you should know what is erectile dysfunctions. According to me, erectile dysfunction is psychogenic, vasculogenic, neurogenic, hormonogenic, drug-induced, and genetic. There have been multiple causes. In younger generation, today we find without having organic cause, psychogenic cause, because of smoking, tobacco, use of substance abuse, etc., watching a lot of porn, also gives rise to erectile dysfunctions. So if you do not want ED, you should know what is ED. Now, ED has also been proven to be having a genetic cause. So there is on chromosome 6 SIM1 gene, which has been associated with erectile dysfunction. It has been studied in over 40,000 patients. To understand the medical therapy, we need to understand what is our physiology of erectile dysfunction. This is the vascular endothelial cell. It produces endothelial nitric oxide synthetase, which diffuses to allow the chemical currency or the endothelium derived nitric oxide, which is the antithrombotic or anti-atherosclerotic molecule, to enter into the corpora cavernosa smooth muscle, converts guanosine triphosphate into guanosine monophosphate with the help of an enzyme guanylyl cyclase. This cyclic GMP, through various mechanisms of protein kinase G, allows the smooth muscles to relax and allows the blood to come inside the penis. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So what do we need for good erection? Basically, we need nitric oxide, which is available from endothelium. And if this endothelium gets dysfunctional, there is impaired production of nitric oxide. So that's the first thing. And that's why erectile dysfunction is nothing else but endothelial dysfunctions. Then we need guanylyl cyclase activators and stimulators. We need cyclic GMP to be there in more bioavailable form. And we need PD5 inhibitors, so the blood remains in the penis and the smooth muscles remain relaxed form. We have a lot of PD5 inhibitors in our armamentarium in the form of sildenafil, tadalafil, sildenafil, and vardenafil. As we age, we lose nitric oxide. Our ability to produce nitric oxide, it is only 85% is lost. It is up to the 60 years, we have only 15% left. Diabetes, friends, is the sexual health tsunami of our century. Asia is the global epicenter of diabetes. Both type 1 and type 2 are at a risk of erectile dysfunctions. Large studies of ours in KEM hospital showed men had ED, early ejaculation, low desire, and females had low desire, and depression was the most common symptom we found in females diabetics at our center. And the normal pathophysiology is there is altered elevated advanced glycated end products seen in these patients, increased levels of oxygen-free radicals, less nitric oxide synthesis, endothelin B receptors binding sites increase, upregulation of Rho-A, Rho kinase, neuropathic damage, and of course, impaired cyclic GMP formation. These patients need help. How do we manage? Whether the problem is in the male or a female, or the solution always lies in the couple. So my advice to you is, in patients who are having sexual dysfunctions, please call the couple together. To rule out psychogenic causes, you need to ask 2 questions. Whether he has morning erections in the last
I reckon there was some technical issue. We're just looking into it, and as soon as it gets solved, we're going to start again we're going to resume the presentation. Apologies for the technical.
No worries. So what we shall do is, while you sort out the technical issues,
Yes, sir.
to keep the ball rolling, I shall ask a few questions to Deshpande sir and Vasan sir.
Yes,
And
sure.
when you are up and running, let me know so that we continue our discussions at the end. We have less discussions at the end.
Sure.
So, Vasan sir, one question I wanted to ask you is paroxetine is not available in 20 milligrams, 12.5 and 25 in our country. Would you up titrate the paroxetine first to the maximum dose before we move on from paroxetine to fluoxetine? Or how would you move around the SSRIs for PPE?
There are a lot of people whose personal choice is sertraline than paroxetine because it's supposed to be less in terms of causing an erectile dysfunction. Younger the patient, older the patient, you can use paroxetine. They seem to respond very well to paroxetine. When I say older, it means those in the age group of 40 plus and having premature ejaculation. So we prefer to give them 12.5 milligram initially to start. We gradually increase the dosage than going into a higher dosage and trying to reduce because it can cause excessive yawning and sleeplessness and mild tachycardia in some individuals. The younger patients seem to benefit more with sertraline, though the data seemed to be skewed more towards paroxetine in terms of statistics, but we have seen younger patients responding to sertraline much better. And the dosage we use sertraline is 25 milligram because it does not cause much of an ED, which paroxetine can cause. And that can be very distressing to a young patient because his libido is more, and consequently he notices even minor changes in his libido. The only issue is if people are not responding to, let's say, paroxetine, the maximum dosage I have used paroxetine is 20 milligram. I do not up titrate it beyond that level. If I need to, if the patient has still got premature ejaculation, the second drug I add is clomipramine, which I add in a dosage of 12.5 milligram once in the day, along with paroxetine. Or I use a local anesthetist cream, which the patient is comfortable because sometimes patients are extremely uncomfortable when you use a local anesthetic cream. They feel loss of sensation and they don't seem to have a recognition of the penis itself. So sometimes they complain that they can't feel their penis. So this is the various, I guess this is my experience, but I'm sure each of us have their own experience depending on the patient population. I think one of the reasons is if there is a secondary anxiety built into these patients because of premature ejaculation for whatever reason, you need to control the anxiety also, and there your other drugs come into play. So that is the general strategy I adopt.
So what you have said is that younger patients, sertraline is a good option. For elderly, paroxetine is a good option. If they don't work on itself, we could try a combination of low dose SSRI plus clomipramine to see if it works. And if the patient is comfortable with local anesthetic, so which local anesthetic, would you ask them to wash it out and then dry it out and then use a condom on top so that the female does not feel numbness? Or
at the age of 40, if you tell a person who's never used a condom, it becomes very difficult and probably a little bit embarrassing for most Indian men. Nobody likes to have a condom. It's only popular with the younger population. I don't think the older men who's got used to normal sexual activity would prefer to wear a condom to prevent premature ejaculation. So I use Prilocaine cream, which comes as Prilox, which is quite useful. And these older men have subtle erectile dysfunction, so it's worthwhile adding a very low dose of tadalafil 5 milligram along with the paroxetine, which gives them much better erection and predictability of erection.
Sir, my apologies. I have to interrupt again. But sir, we're ready to go share again. So I request team RX events. Yes, sir.
Look, let Vasan sir finish what he's saying.
Oh, I'm sorry.
Then we shall move.
I'm sorry, sir. Sir, please.
Yeah, that's it. I just made a point that sometimes if you consider the patient to be having significant premature ejaculation in a diabetic population who's 40 plus or 45 plus, I would, along with PDE5 inhibitors, though he claims that there is no erection difficulty, I would add a PDE5 inhibitor, specifically a tadalafil, which gives them the liberty of having the sexual activity along with a slightly harder erection, which sort of delays the sensation, and a single drug is more effective in these men.
Sir, has there been last question before we finish the topic on ejaculation? there's certain papers or some anecdotal lectures I've heard, people using long-acting SSRIs and on top of duloxetine as on demand. Is that any experience on that lines or any tip?
I've not been very hot on duloxetine, basically because my experience with paroxetine has been very good. I have used duloxetine only in patients who do not respond to paroxetine and this one. And yes, I have used duloxetine on demand along with sometimes these very persistent premature ejaculation who persistently ejaculate before even penetration. So there are some who, ejaculate just before penetration or just after penetration within 30 seconds, which can be quite distressing. So in that group, I use clomipramine 25 milligram in the night along with an on-demand duloxetine. Seems to work very well in that group. So that's the area where I use it.
Thank you so much, sir. Thank you so much. Over to you, Shlok, and over to RX Events for continuing Dr. Jumani's lecture. Over to you, Jumani, sir.
To counseling and lifestyle measures. We have other things besides injections, vacuum therapy, intraurethral drugs of prostate, prostaglandin. If not, we send our patients for implants. But counseling and lifestyle measures happen to be the main basic stay of treatment for erectile dysfunctions. We have now got 17 years of clinical experience with PDE5 inhibitors, and what we have found is adequate counseling at the beginning of the therapy will improve the adherence of the treatment and removal of the patients. Counseling and mindful-based group therapy works fantastic. We have 4 different types of PDE5 inhibitors: sildenafil, tadalafil, sildenafil, and vardenafil. We have 20 years of experience with sildenafil. Its onset is within 30 to 60 minutes. It is lasting for around 6 to 8 hours. But tadalafil, the onset of action is 2 hours, but lasts for 16 hours. Tadalafil, we have enough studies to prove that it even works for 12 weeks continuously if it is given. The improvement is seen fantastic. Even if the HbA1c is more than 7, or even if the patient is having hypertension, these drugs act very well. Sildenafil is a novel drug, 100 milligram, works for 10 to 12 hours. Less inhibition of PDE6 and 11 enzyme, so less visual abnormalities and less myalgias with these patients. Vardenafil, new kid in the block, fastest onset of action, a beautiful drug which is there. So if you want the patients to have immediate effect, give them vardenafil. But there are 40% patients who are not responders. They do not stimulate themselves. They don't take it in proper dose. They don't take it in the adequate amount of time. They take it just before dinner or before having sex. They take it after heavy meals or alcohol, and they take it when their partners are not interested. Sometimes they get fake drugs, so they buy it from the internet. The new strategy is we give 2 PDE5 inhibitors, combine them, and there was a beautiful study done with tadalafil and sildenafil. Low dose tadalafil was given against, and this was studied, and they found better improvement in this section. So we have 4 different type of PDE5 inhibitors. Now, with this 20 years of our study with PDE5 inhibitors, we have now understood that these are also useful for lower urinary tract symptoms, for pulmonary arterial hypertension and Raynaud's phenomenon. It's a beautiful drug which has been now used. PDE5 inhibitors have a lot of side effects. Mainly it's headache and visual disturbances. Contraindications are nitrates, recent cardiovascular events, certain penile defects, retinal injuries, anemias and leukemias. Nobody has developed blindness with PDE5 inhibitors. There is no loss of visual acuity or contrast sensitivity. And these are all transient effects. We see central chorioretinopathy in some patients, but that is reversible. We have now films available of sildenafil and tadalafil, which we can take, which bypasses the liver functions. And so you can have no side effects with this. And they have faster onset of action. So chronic therapy with PDE5 inhibitors is supposed to be the ideal choice or the valid choice in patients who are diabetics, hypertensive, dyslipidemia. What is new? We have avanafil, which is a wonderful drug which will soon hit the market. We have SLX2101, mirodenafil, and lodenafil. These are the 4 new drugs which will soon hit the market. The best now which people are trying and is available with limited success are low-intensity extracorporeal shock therapy and platelet-rich plasma. So the pharmacotherapy is with all these drugs, novel molecules which I have just mentioned. We have novel targets which are now being studied: platelets, microparticles, galanin, sonic hedgehog, stem cell, gene cell, nanoparticles, etc. Buried penis syndrome can be treated. This was our study with 1 gram of metformin, arginine gel, and sesame seed oil application. Within 24 weeks, patients start seeing their penises very well, and we put them on PDE5 inhibitors, they start getting erections. So we need to understand, if we want to give it as a symptom, we give pharmacotherapy. But we want to give it as a cure or as a disease, we need to give phytonutraceuticals or some regenerative. PDE5 inhibitors do not increase the desire. There are 40% non-drop. Diabetes also comes with hypogonadism. It is the free testosterone. How do we overcome this therapeutic gap? We need to understand that if we combine testosterone with PDE5 inhibitors, you will have fantastic results. Dr. Paresh Dandona produced beautiful result that in most of the diabetics, there were low levels of androgen, estrogen receptors and aromatase levels. And by giving testosterone in a short course, it was found that even the diabetes was reversed. Forget getting the testosterone normally, even the reversal of diabetes was seen. So phytonutraceuticals, if you do not want to give testosterone, helps in certain extent to treat erectile dysfunctions. We have L-arginine, we have fenugreek combinations which are available. Beautiful results in improving. The mechanism is the fenugreek has a similar chemical structure as testosterone, so it displaces the globulin bound and makes the free testosterone more available. My friend Dr. Jyoti Dev used insulin pumps to cure not only diabetes or to improve the hyperglycemia, but also improve sexual dysfunction. So we have all these regenerative therapies which are there. In 20 years of our research with PDE5 inhibitors, what we have found is, along with PDE5 inhibitors, counseling and lifestyle changes have been to prove. Lifestyle means you have to have diet, exercise, sleep adequate, avoid smoking, alcohol, etc. Mediterranean diet helps very much. Now, new drug, the old and the golden drug metformin is also used as an adjunct with the PDE5 inhibitors because it improves endothelial health. SGLT2 inhibitors are having, because of their class effect, because of their good effect or properties, it reduces hyperglycemia, hypertension, and dyslipidemia. So the organic causes of erectile dysfunction are mainly covered with metformin and SGLT2 inhibitors. These patients, if they take these drugs and if the levels, if the metabolic syndrome is controlled, they don't need PDE5 inhibitors and their physiological erections do appear. So the ideal prescription should be this. We should have counseling, OHA, whatever insulin. If you prefer OHA, metformin and SGLT2, statins, antihypertensive should be ACE inhibitors or ARBs. If you want to give beta blockers, nebivolol is the best. If you want to give diuretic, indapamide is a low dose PDE5 inhibitors, low dose testosterone, L-arginine supplements, etc. A diabetologist should ask what is erectile, ask their patients for erectile dysfunction. They should check feet, retina, and oral hygiene, do a CBC age reader, give the right hypertensive, check for depression, and also do nutritional intervention. And also the problem is, my take-home message is, the onus of sexual health of our patients lies with we physicians. Take a detailed history. We have all these PDE5 inhibitors. They don't increase the desire. There are 40% non-responders. The Badsha is testosterone, but we need to give it with caution. We have patients who have developed azoospermia, heart failure, and prostate issues. So be passionate in the bedroom like our Prime Minister. Even in the bedroom, you need to be fearless, etc. So friends, erectile dysfunction is not an option for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. So for male sexual response, for desire, we have testosterone, L-arginine, and fenugreek. For erections, we have L-arginine and PD5. So what you want? Everything is possible. So today, for erectile dysfunction, we have got so many things on our armamentarium that this is a symptom which can be cured very well. Whatever may be the cause, all the causes are modifiable and can be halted and even reversed. So it is really nice to know today that erectile dysfunction is a correctile dysfunction. For my friends, if you have patients of erectile dysfunction or any section, don't send them to any quacks. Send them to good sexologists and you will see that he gets a good erections. Friend, this is my book, Sexual Health Manual, Sex Has No Expiry Date. My last slide. So friends, diabetes is the sexual health tsunami of our century. ED is highly prevalent and is the earliest marker of cardiovascular disease. Sildenafil, tadalafil, sildenafil and vardenafil are effective treatment. Low-dose PD5 inhibitors and statins can be ideal choice for diabetics. Testosterone low-dose can be used with caution. L-arginine supplement with fenugreek is a boon. Diabetes reversal is a fact and not a myth. If you do this, please friend, trust me, erectile dysfunction is a correctile dysfunction. So don't let your diabetics die in bits. If you do so, everyone's sex will have no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.
Thank you, Dr. Jumani sir. That was a very eloquent talk. I have two questions for you. Number one question, you mentioned about low dose testosterone. So what is the dose you want and how long? Hello? Dr. Jumani sir? Seem to have lost Dr. Jumani sir. I think I can't see Dr. Jumani. I think he's there. Jumani sir, we'll come back to him. I think till he's, we get the link up and running with him. I invite Dr. R.P. Singh, who's going to tell us something which we don't talk, something which is very important. We need to talk about sexually transmitted disease and what a physician should know. Over to you. Sir. Over to you, sir. I think the audio is not very hearable.
Venereology or VDs, and now it is STD. And then in England or UK, they call it as gum also, gum clinic and all that, genitourinary medicines. And many of the time, we people even get confused. Anyway, coming to the topic, it is increase, the diabetes invites a lot of infections because of hyperglycemia and glucosuria, decreased humoral and cellular immunity, then glucose-dependent intracellular adhesion, molecular excretions, etc. So any of the diseases can be there in more frequency and severity as well. And they also include autonomic neuropathy as well. Then more frequent need of medical interventions also decreases the well-being of the person, or thereby indirectly inviting the STDs or sexually transmitted diseases. And this is with the population having DM, diabetes mellitus type 2. We come across not many cases in time, and most of the time, if we are not careful or the patients are not also attentive, they also don't mention about the history of diabetes, etc. And same thing had happened with this fellow. And ultimately, when we got it tested, the sugar was 110 and 198, as you can see in the description. And the vaginal introitus and everywhere it was full of discharges. And the discharge is the commonest condition is candidiasis. As you can see, it is more prevalent in genital STDs. Otherwise, other parts of the body can also be involved, perianal area, etc. The common mycotic genital infections lead to itching as well as burning at times, but in males it is mostly as the balanitis and even postobalanitis, because if the frenum is there or the prepuce is there, the irritation or the opening or the getting it back retracted becomes very difficult at the time. In the females, it is vulvovaginal candidiasis, most commonly seen as itching or simple white discharge, they call otherwise. Here, the Candida species is commonly seen, albicans, glabrata, and tropicalis, and this is more with the Candida as even other fungi. And in post and of course the uncircumscribed or the aging conditions, they become obese and the movements also become sluggish, the hygiene is poor. So even in diabetic cases, the washing of the genital organ is very much important after the urination or even defecation, which is routinely there, but most of the time when we examine the cases, it is not like when we feel the fecal matter around the perineum area or the places. Even the clothing also found to be stained. So routine hygiene is very important. Wipes and sprays can be used, but not so frequently. The fresh water or the water as such is very good, and with the soap, but again the rinsing has to be proper, even with the sprays or the wipes. Uncircumscribed males can be suggested for the circumcision as such. Otherwise, the prepuce has to be retracted at least once, if not twice in a day, for the proper wash. Most of the time, because the surface area increases, we can find different type of infections, not only the candidiasis, but other infections as well. So using of the clean water is very, very important, and soap has to be also very mild. Don't go for the fancy soaps rather than simple soap and water. And as you know, the inhibitors and genital infections are related, and most of the time these new drugs do also increase the urinary and genital infections commonly, and what the medication is being given is also to be known is very important. And they increase the glucosuria, and preferably conditions are pathogenic and which thrive over the grow as well, resulting into many different types of genital infections. The genital infections may be mild to moderate in nature and respond very well to the standard treatment. The case which I had shown responded very well, but here again it is very important that the partner has also to be treated without fail. Otherwise, it keeps on occurring, and frequently we may come across the different type of infections as well. But as such, this doesn't require any discontinuation of the SGLT2 therapy as such. Then as you can see here, the prepuce is not retracted properly, and it was not possible in this case in toto. And most of the time the females or the spouse is not having any problem. And whenever the contact is there, sexual contact is there, most of the time they get annoyed by this activity. And again, the female also or the spouse also suffers with the itching and candidiasis or different type of infections most of the time. Then urogenital infections are very common. They may be UTIs, balanitis, balanopastitis, and accessory glands infections in the male. And in the females, it may be vulvovaginitis and urinary tract infections. If they are not taken care properly, the anal or the perianal infections do also increase. There may be asymptomatic bacteriuria and symptomatic urinary tract infections at the time, and that is the main problem with the people with the diabetes and all that. Most of the time it may be asymptomatic, even in female or in the male as well. So leading to the problem to the sexual activity, certainly because of that the spouse may suffer with the different types of infection and coming frequently to the clinics, or they may be going to the chemist and taking their own OTC type of the management. So asymptomatic bacteria infections is almost 3 times higher otherwise from the normal population. Melanopostitis is also very important along with the balanitis. So at the time, if it is recurring and frequently occurring in the patient and they are not able to clean it properly, most of the circumcision clean it with simple soap, and even what most of
Line is a little bit disturbed.
we come across like that. So one has to be very specific that it has to be washing of the genitals rather than the gargling or using it for the purpose. Then, as I said, the accessory glands are there. They may also get infected, and most of the time the poor sexual desire and everything because of the burning pain, micturition, etc. They may have unpredictable intracanaliculaar infections leading to sexual activity diminished. Same thing if in the female is also very, very problematic. Most of the time the person or the husband will come with a condition saying that it is not there, nothing is there in the wife, but when we stress upon and then we find out that they are having this asymptomatic bacteriuria or asymptomatic infections. And as you know, the vulvodynitis is common, and most of the time they presume it or assume that it is because of the poor menstrual hygiene or something like that. Most of the time they ignore it, or even apply something of their own, or the neighbor's opinion, etc. are very, very crucial at that time. So the proper counseling at the diabetic clinic for the sexual hygiene or the perineal hygiene is as good as important rather than the medication after the STDs, getting it or treating it properly. Then you can see it is here the wart, it is with the HIV infection as well, and these warts are again treated by different topical applications. Most of the time, as you know, the most steroids are used, and the treatment of these become difficult at times because of the diabetes if it is not controlled properly. And especially in the females during the pregnancy, they may cause problem. We can't treat it with the proper medication, that is cauterization or something like that. This is again a case of herpes. Very frequently we see it, and treatment is very difficult, of course, and it leads to ketoacidosis also, thereby complicating the diabetes as well. Hence, we should know that sugar is under control and dose has to be adjusted accordingly. And nowadays, as you know, HIV is also prevalent. There are many antiretroviral drugs which can lead to improper dosing of the insulin or anti-diabetic oral systemic preparations, and at times different infections, and the drugs also interfering with the medication. Hence, they have to be taken up in a serious matter, as a serious matter, of course. And anti-diabetic, as I told, that increase the level of metformin, etc. So the dosing has to be adjusted as per the need of different cases. And And now coming to the syphilis and other STDs, as you know, the neurosyphilis or something like that, tertiary syphilis and the diabetes can be also very much susceptible to that. Other way around, hence the syphilis or any symptom related with neurosyphilis has to be taken care of properly. LGV and other STDs like chancroid, pneumonitis, syphilis, etc. may be difficult to treat at times, and hence diseases and sexuality or sexual urge decreases because of the STDs as well as diabetes in the most of the patients, and they have to be taken care properly. Otherwise, they cause certainly a lot of problem in their activities or sexual life. And without fail, the partner has to be treated properly and with the proper guidance about the non-transmission of the HIV or other STDs by using the condoms and promoting the condoms by proper counseling and education to them. Thank you very much.
Thank you, RP Singh sir. Sir, I have one question for you. What about use of symptomatic discharge, treatment of symptomatic discharge without testing? Abroad, that's this concept. In India also, some kits like VDM kits are available. What are your views on use of those? RP Singh sir? Seem to have lost RP Singh sir. I think Dr. Deshpande sir is still there, sir.
Yeah. Yes, yes.
Sir, one question.
I'm there.
Sir, one question to you. On female sexuality, sir, Fibanserine was launched in the market.
Yes.
Any experience of the use of Fibanserine, sir?
Initially, it was thought to be useful, but because I have not used myself in any of the female sexual dysfunctions, because our approach is that means it's basically the desire is not only manipulated by medications. It has psychology to play. And in women's psychology, the desire is basically dependent on many factors. Most importantly, relational factors. That too, there were studies where they found that even before marriage and after marriage also, the relational factors are more important. The most important thing which is missing in our society is the importance of touch. When we interview many women, they say that their partners don't touch them. Means all the erogenous zones which a woman has in plenty in her body, they have not been sensitized and aroused. So rather than Fibanserine, I think the counseling part and relational aspect, actually the bedroom techniques has to be told to these patients or their partners. That is more important.
So as you summed up your slide, an interested and loving partner is the way to go forward.
Yes, yes, that's very true. And that's why we always say that don't counsel a woman alone. Always ask her to be with her partner. And same thing is for a man also. Couple counseling, we advise more.
Okay. I have a question to Vasan sir. Sir, if you are there. Dr. Jumani sir is not there. When he mentioned on low dose testosterone use, I have no experience of low dose testosterone use. Either I use it or I don't use it to the desired levels. Your experience, sir?
I also don't believe that there is anything called low dose testosterone, because very difficult to, decide who requires a low dose and absorption. So probably he's talking because injectable, when you use an injectable or a gel, you are using it on a daily basis. If it's a gel, injectable gives the maximum dose, like you mentioned, the peak and the trough effect. Whereas I don't know whether he is planning to use the oral tablet form, Andriol Testocaps, which is a 40 milligram tablet on a daily basis, which is really a subtherapeutic dose. I really have not been familiar with using it. I don't know whether he is using it to prime the endothelium to improve the nitric oxide levels, but I'm not sure that usage. I have never done.
Thank you, sir. Thank you, sir. Dr. Singh, sir, if you are there, can you answer? Did you get my question when what I asked you about symptomatic discharges? Patient comes to you, diabetes, well-controlled diabetes, comes with a discharge, may have had a history of unprotected exposure. yes, you cannot do an HIV test now. What are you going to do? Are you going to treat him with a blanket? Is there a blanket regimen that you follow? Because it may not be practically feasible to do the testing for everything.
Truly speaking, we don't need any test, and by proper history, we can come to know whether it is symptomatic or disease or whatever. Because if it is diseased, some STD is there, there will be some other symptom as well, burning, itching, or irritation, or something like preputial irritation. So if it is not there, then certainly we will not like to treat it. Maybe, as you say, symptomatic, but not because of any disease. Otherwise, if you say the diabetes is there, the diabetes has to be treated, because at times some infection can be there prevalent, which may be causing some irritation at times. Otherwise, at the time, they may be asymptomatic.
If they're symptomatic with painful discharge, sir, what blanket treatment, or how would you go about that, sir?
Certainly,
Because
we will go. We'll go
some
for
of the
urine.
companies come up
Yeah.
with some predisposed kits that are available. So do you use that, or do you advise not to use those kits?
No, not those kits, because they are at times the chemicals, if they apply in vigor or whatever, what they want, quick relief, they apply something like people most of the time come with the Dettol application or Savlon application for cleansing purpose, because they have some irritation, some discharges, and they get burned. Or even simple betadine or povidone iodine solutions they apply and they get burned. So the ready-made preparations are certainly not to be used, and even the sprays and the chemicals, what are there, the hand washes or the things they use, and they will take it on your palm and then they apply. So that they are not, the best thing is to use simple soap water. That will be ideal.
Thank you so much, sir. I hand the meeting's proceedings back to Shlok to kindly end the session, and I would ask everybody to kindly put their video on that Shlok can take a photograph for all of us together.
Thank you.
Yes,
Vasan, sir.
I thank Dr. Mithun Bhartiya sir for moderating the session really very well, and covering all the topics along with really very knowledgeable, scholarly questions and very interactive discussion with all our speakers. I thank Dr. S.S. Vasan sir from Bengaluru. I thank Dr. Sanjay Deshpande sir from Nagpur. I thank Dr. Deepak Jumani sir from Mumbai. I thank Dr. R.P. Singh sir from Nagpur for their time and for their presence, and a beautiful and a very knowledgeable talk. I would like to conclude this session, and just a good news that we have over 3,773 people online for this conference.
That's good.
Okay, lovely.
Wonderful.
Thank you so much, Shlok. Shlok is a young budding doctor who's got a who's going to jump leaps and bounce, and I'm sure he will leave his father behind, and that his father would love that as well in the coming years.
Thank you.
That's great.
Thank you so much, sir. They were very kind words. Thank you.
Keep it up, Shlok.
Thank you, sir. And we also ask you to join tomorrow for our sessions, and have a safe evening. Have a good evening, sir.
Thank you.
Thank you so much.
Thank you.
Wish
Thank
you all
you
the
very much.
best. Stay safe.
Yes,
Thank you, sir.
Thank you all.
Thank you.
Thank you.